Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and a very good morning everyone. Welcome back to our International Symposium on Medical Devices and Technology 2023 S-MEDiTEC 2023. My name is Muhammad Ifan Afan. I will be the chair for this morning's session.
Assalamualaikum, very good morning. I hope everybody can hear me clearly. Thank you, Cik Naufal. My name is Saldia. I'm from the Medical Device Authority. And my topic today is on the ensuring safety of medical devices in the new era of technology. Okay. So, but before we go on further, let me just introduce Medical Device Authority. Basically, under our leader, the Chief Executive of MDA, we have three technical divisions, okay, and one administrative division, which I'm not showing here. Okay, the first division is on policy, industry, and international affairs. Then you have pre-market control and post-market control and enforcement. Okay, but just recently, my division, policy, industry, and international affairs, because it has a big scope under it, to make it more effective and more efficient, we have subdivide this division into two. Okay, so now I'm holding a policy and strategic planning division. Okay, and the other division is industry and international affairs. Okay. So we're talking about technology and innovations, yeah. So let's just, for medical device, look into what we had experienced, yeah, when we had the pandemic, COVID-19 pandemic. Okay, everybody was panicked, yeah, looking into solutions and best efforts. And there was a lot of teamwork between all stakeholders, yeah. So behind the bad happenings within the COVID-19 pandemic, there are also benefits or good things that are happening around in Malaysia and also around the world. Okay, so everybody was working together. Yeah, even between countries, yeah, they are offering solutions, and new devices have emerged. Okay, some devices became very popular. Yeah, for example, the face mask, PPE. Yeah? We have oximeters, oxygen concentrators, we have the ventilators, and so on. So the medical device industry is actually, or was actually growing very rapidly, yeah, since the COVID-19 pandemic. It started actually at the end of 2019, yeah, but only in early 2020, then the pandemic was declared. So advancements and better components, yeah, became available, and medical devices, it evolves, yeah, along with broader medical device technology trends. For example, we have the, I can remember we have the stethoscopes that are now wireless. Yeah, the use of Bluetooth technology was used. So you don't see doctors wearing them on their neck anymore. They put it in their pockets. right? And we have like digital or remote surgeries being done because it's difficult for doctors to go to these areas where there's a lot of pandemic happenings. Yeah. And also we have like treatment diagnosis that are done remotely. Okay. Even for regulators like MDA, we look into remote audits and remote assessments. So those are the things that are good things that are happening from the COVID-19 pandemic. So in 2021, yeah, the 2020 happenings has brought a lot of changes, and it has affect a lot of people in our daily life, So, everybody was working together. The doctors, researchers, companies, and countries collaborated, and sharing of technology has been done, and so everybody is putting a lot of effort to stop this virus and to make sure that, everybody knows that infected by it being controlled, treated as efficient as possible. Okay. So as we enter in 2021, this trend towards globalization, sharing of knowledge, and setting common goals, it continues, and in several areas, especially in the medical technology. So we see the growth of medical device industry, and it's expected in 5 to 10 years. We have like a 5% increase every year. And I think there was a data showing that in the US, it has in 5-year projection to reach around 800 billion by 2030. So this is a very big amount. And Malaysia, we have some share with that also. Yeah. So I think Malaysia is around 2-point-something billion. Yeah. Okay, so it's quite a good growth, for the medical device industry. Okay. So new digital technologies, such as the Internet of Things, artificial intelligence, are tools that are typically implemented as software in medical devices or software as medical devices, and are fulfilling or fueling the digital healthcare sector's ongoing quest for better things. And due to these innovations, diagnosis and treatments can be done even proactively. And when medical devices are connected to digital infrastructures, such as the internet, they can support the real-time transfer of important diagnostic data to information technology systems. So, so through machine learning, AI, it can use to actually quickly identify patients' health patterns and also anomalies, so doctors can provide treatment as soon as possible. So let's look at the artificial intelligence, So AI-based medical devices, are improving capabilities and revolutionizing healthcare by assisting professionals to reach accurate diagnostics and improve treatment for overall patient care. This includes AI monitoring devices that monitor while they treat. For example, diabetic patients can wear devices that sense and monitor blood sugar levels, signaling an alert when they become dangerously low. Okay, and we look at the Internet of Things. So IoT, which has a huge impact on medical devices, has provided medical devices with a means to work remotely and wirelessly. Okay, this means medical professionals can gather and manage data from remote locations in real time. Okay, the 3D technology, it quickly found its way into the medical sector and has transformed the health industry by creating on-demand medical devices. It does this by turning a digital model into a physical representation with the use of appropriate materials that can print in successive layers. Even CT scans, X-rays, MRI scans, and ultrasounds are being fed through 3D printers and are then converted into physical 3D models. And 3D developed devices are easier to procure and thus make surgical procedures more lucrative and oftentimes more successful. So there are some these are some of the examples and of new technologies in the medical device industry. So with these advancements and better components becoming available, medical devices evolve along with broader medical device technology trends. The future certainly looks bright for medical devices with the continued rise of technological innovations. Said that, in spite of the significant benefits, there are challenges, especially to regulators like MDA. We have to really look into patient safety that comes together with new things, new specifications, new materials, new platforms, and we have to look into whether what is being designed, what innovations that are introduced actually provide benefits and also safety to the patients. What claims that come from the manufacturers are validated and also verified. Okay. And we look into the effectiveness of the innovated medical device, and also in software as medical device that are used in AI, machine learning. We have to look into cybersecurity. We do not want people to tamper with the performance of this device, when it is being used. And also there are also limited sectoral data governance framework. This has also to be looked into. So regulatory regulatory issues impact on the whole life cycle of the innovation. They have to be considered in the early steps of the medical device design and development. During preclinical, clinical evaluation, product regulatory evaluation, manufacturing, and post-market surveillance. So for this reason, the relationship between medical device developers and the authority is very critical. The authority approval is required before the new product is placed in the market. Therefore, governmental policies and actions in this field constitute the external framework for medical devices innovations. However, as medical devices become increasingly complex, the responsibility to assure the safety and performance of the devices also will have to fall on the industry, the practitioners, and also the patients themselves. Indeed, developers have to prioritize regulatory issues even at the earlier design and development stages of the innovative medical device. Okay, let's skip this. All right, so when we look into development of medical devices, we have to firstly look into risk management. This is part of basically the brain, when you want to come up with something, you have always to look into the risk management. We look into the compliance to the essential principles. We have as much risk as possible, and we have to identify, ahead all the hazards that are possibly that could come together with the use of the device. Okay, so for this, we have the ISO standard, ISO 14971, for all manufacturers to refer to and to use, when they are developing their device. And this is a live file, The ISO 14971, the file into risk management of each product has to be kept, and regular monitoring on the status of the safety, has to be included in this file from time to time. Okay. Let's just look at the full regulatory framework for medical devices in Malaysia. Okay, we have the Act 728 and Act 727. These are the two acts that govern the medical device and the players of the industry, in the medical device sector. Okay, the Act 728 gives powers to MDA and Medical Device Authority to implement all regulatory requirements that regulates the conformity assessment bodies, the establishments are the manufacturers, authorized representatives, distributors and importers, and also the users of medical devices when it is being placed in the market or is being used in the hospitals and healthcare institutions. Okay, and we also facilitate the industry, in my industry, and we are very actively collaborating or closely collaborating with all the major associations for medical devices industries in Malaysia. Namely, we have the Association of Malaysian Medical Device Manufacturers or medical device industries in Malaysia, AMMI, and then we have MMDA, also comprising of the industry players, from the manufacturers, from the importers of device, authorized representatives, and so on. And then we have MACMA, the Rubber Products Associations, and also the Dental Association, and the IA, and also we have Prantim. Prantim is local manufacturers of medical devices. So the process, this is to show you just the registration process of medical devices. We also have another process where we have the licensing of establishments. Remember, establishments are manufacturers, authorized representatives that representing the foreign manufacturers. We have importers and also distributors. Okay, those are licensed establishments that need to be licensed. So in the medical device registration, firstly, all developers of medical device, they have to know that whether their product are actually medical devices and refer to its intended use, and look into our medical device definition. The definition of medical device is actually harmonized worldwide. We from Malaysia, we followed the Global Harmonization Working Party, Task Force, Global Harmonization Task Force definition, GHTF. Now they are called the IMDRF, International Medical Device Regulatory Forum. Okay, they have a definition for medical devices that are adapted or adopted by all countries. Okay, so when a developer, a researcher wants to develop the device and place it in the market, they have to aim for its registration in the regulatory system. Okay, and they have to know what are the requirements of the regulatory process. Okay, and they have to put their device into conformity assessment procedure. So in Malaysia, the conformity assessment procedure is done by the conformity assessment bodies. And we have, I think, more than 20 conformity assessment bodies that are registered with MDA. And like in the screen, I showed you just some of the CABs, it's not promotion, it's just some examples, for you to see. There are a third party external body that does the conformity assessment procedure. So with the certifications, testings that have been done, these documents are submitted for registration and in our online system, MedClass. And we will review all documents, and if everything is we will provide the approval and issue the registration certificate. Okay, there's some fees involved. Okay, and now manufacturers or ARs, they can print your certificate online through the MedClass system. You do not have to get the printed certificate from MDA now. So it's a faster process. Okay, and for all the users and anybody or stakeholders who would like to know whether a device is registered or not, we can do a search in the medical device register. Okay, so the public search link is available in our MDA website. And after registration, if there are changes, it can also be done through the MEDCAS system. And also when the registration has expired, there's a re-registration process where the requirement is down to minimal, and registration process can be done, as fast as possible. So, but manufacturers and ARs are always advised to submit a request or application for re-registration like 1 year or 6 months at most, before their expiry. Okay. So now we look into the ISO 13485. This is the Medical Device Quality Management System standard. Okay, this is ISO standard. When we talk about ISO standards, it's an international standard. So most countries are adopting, ISO or IEC standards. So I think the heart of the regulatory requirement of compliance lies on ISO 13485. So the controlling of the ISO 14971, like I mentioned just now, is also part of the requirement for ISO 13485. Okay, so this standard, it includes requirements related to the methods, facilities and controls for designing, manufacturing, packaging, storing, installing, and servicing of medical devices intended for human use. So when you use ISO 13485, it has to be read together with the regulatory documents like the Act 737 and also the regulations under it. So in addition, device manufacturers are required to collect post-market information, including clinical data as part of their risk management system, that I mentioned before just now. Okay. So an advanced regulatory research has to be done in critical aspects such as identifying appropriate clinical endpoints and key scientific questions. In this way, collaboration with government agencies, academicians, device industries, patients, organizations, and professional associations may provide valuable information for more effective and efficient regulatory review process, reducing medical device innovation costs and helping to faster delivery of safe new products to patients. So medical device technologies require researchers and regulators to have strong scientific background and knowledge to ensure that efficient verifications and marketing approvals that assure safety, quality, effectiveness, and performance of the technologies according to the intended purpose of the device. Regulation should occur in reasonable time, to allow patients and healthcare providers to access the most advanced medical technology. For example, if you have software as medical device, us as regulators and also the manufacturers, they have to know what are the evidence to provide or to look out for when we access the device new functions. So those are some of the challenges or things that we have to put in place before a medical device or a new device is put in the market. It has to be clear and transparent and to ensure safety and efficacy of medical devices used on patients. But they also have to be flexible enough, responding to the medical device innovation and global market needs. Innovative products need to be developed of, more appropriate assay methods and streamlined regulatory and scientific evaluations to encourage innovation and ensure more expedite delivery of novel, safe, and effective innovative medical devices to patients. For example, like when we had the pandemic, Malaysia, together with other countries, through the Global Harmonization Working Party, through the ASEAN Medical Device Committee, these are all international committees that we are working together with to come up with guidance documents. We have the documents on the emergency use authorization. For Malaysia, we have the special access route, the conditional approval route, to enable self-testing kits, self-test kits, that can be used by the layperson, okay, like earlier on, only professionals, healthcare professionals can use test kits for communicable diseases. Okay, but because of the urge to have a timely or quick diagnosis of this disease, we have to be flexible and as such find a way to enable even the users, the end users, the home users, to test on their own and find out if they have got this disease and look for treatment. Okay. And we have worked together, in software as medical device, coming up with also some guidance document to make sure that there are validation process, verification process, to look into the, also classification of the software according to what is intended for. Yeah, so we are working together with the other countries to make sure that our requirements are harmonized, okay, and we do not have a redundant process. So as such, this is hoped, to facilitate the industry, to make sure it is a win-win situation for both, the industry players and also the regulators themselves. When there is less work at the pre-market stage, if let's say you from Malaysia, if you can recognize the works from other countries such as the the 5 recognized countries like the EU, US, Australia, Canada, and so on. Yeah. So our work at the pre-market side is less, so we can focus, pay attention more on the post-market and also enforcement activities. Okay, so this is also being practiced from by other countries, and it is hope for Malaysia we can have more bilateral collaborations with other countries, and as such, harmonization, recognition, convergence of requirements between Malaysia and other countries can be achieved, and as such, all regulators and also medical device industry players in Malaysia and also elsewhere in the world, we can benefit from this harmonization and convergence activities. So I think that is all for me. This is our contact information for MDA. Yeah, we have a phone number there, and there is a link to femes.mda.gov.my. Okay, so this is where anybody can just drop in a line or a question or query, or you want to say anything to MDA, bring to MDA's attention, you can go through this link and provide whatever you have in mind to MDA. Okay, so our website is mda.gov.my, and there's our email address, general email address, or you can email me directly if you have any queries for me, salvia@mda.gov.my. Okay, and I understand there is some questions for me. Yeah, maybe I should stop sharing first. Okay. All right. Okay, thank you for the question. Okay, for the first question, like I mentioned just now, yes, we have a special round, for devices that have been approved by the recognized countries. When I say recognized countries, these are the, I think, 6 now countries that we recognize, which is the EU, US, we have Australia, Canada, Japan, and also the UK. Okay, recently, as you know, the UK has, have its own regulatory system. So we are also recognizing that. We have the UKCA, UKNI, and then the CE marking. And later on, we will have the MDR, EU MDR requirements. And whatever approvals from the EU market, we recognize. Okay, so if you have that approvals from these countries, the 6 countries, when you have to go through CAB to do a verification process. It's a fast process. Okay, so with the certification of verification from the CAB, then you submit all the documents to MDA. If the documents are complete, okay, for class A, usually is between, I'm answering both questions one time. Okay. So if all the documents are complete, for class A, it can take up to 2 weeks. Okay, it's 21 days. Yeah, but we are reducing it. Yeah, I think now mostly is within 2 weeks. Yeah, the approval process. Because we have a checklist that we have to go through, and then we will check documents whether, even though it had gone through the CAB, all documents have been uploaded and all the documents are complete. Yeah. Then we will issue the approval. For class B, C, and D, usually they share the same timeline. I think now is 60 days. Okay, 60 days, but we are putting a lot of effort to make sure that the time that we take for approval is minimized, and most of the time now is about 30 days. Okay, for class B, C, and D, it's 30 days. Okay, unless there are some issues, we have to return the application to the applicant. Then there will be more time taken by the applicant that is not under our control. Okay, so once all the documentation are complete, for class B, C, and D, at most is 60 days. It's actually depending on the traffic, the queue. But now, usually, at most is about 30 days. Yeah. Okay, so I hope that answers your question. Is there any other questions? So yeah, it does not have to go. Does not have to go through another endorsement. It's not to say it's an endorsement. It's an approval process of at the MDA end. Yeah. So even though it has gone through approval process in the US, we have to look into requirements also that are related to the requirements of the Act, Act 727. We look into the licensing, and we look into the history of post-market when it has already been sold elsewhere in the world. Okay, then you give the approval. Thank you.
For our next presentation, I would like to invite Dr. Salwa binti Muhammad from University Tun Hussein All Malaysia, UTHM, to present her research. Dr. Salwa, the floor is yours.
Okay, thank you. Can you hear me, Mr. MC?
Yes, I can hear you there.
Okay, thank you. So, can you see my slide?
Doctor, can we have a 5-minute break first? We are experiencing technical difficulties right now.
Sorry, your voice is not clear.
Can we have a 5-minute break, Doctor?
Okay, 5-minute break. All right, okay.
We are experiencing some technical difficulties right now.
All right.
Testing 1, 2, 3. Testing 1, 2, 3. Testing 1, 2, 3, 4, 5, 6. Testing 1, 2, 3. 1, 2.
All right, I will share my slide. Okay, so can you see my slide? Okay, thank you. So, Assalamualaikum and good morning, everyone. First of all, I want to thanks to the organizer for inviting me to share our current research in this symposium. So, today I will present on title Carbon Footprint of a 3D Bone Tissue Engineering Scaffold. By the way, my name is Salwa binti Mahmud. I am a senior lecturer of Department of Mechanical Engineering, Faculty of Engineering Technology, University Tun Hussein on Malaysia, UTHM campus Pagu. So,
Salwa, sorry, can you make
yeah.
it in the slideshow mode?
This is the slideshow mode.
Unshare, then share again.
Okay, I stop first. Okay, share. Okay, can you see my slide?
I think just better just share screen.
Share screen. Share screen. Okay. Can you see my slide in the slide mode?
Yes, right.
Okay, sorry. Okay, so introductions. Okay, so next, I will brief on the 3D bone tissue engineering scaffolds. So 3D bone tissue engineering scaffolds are structures designed to support the growth and the regeneration of bone tissues. And they play a crucial role in the regenerative medicines by aiding the repair of damaged or lost bone tissues due to trauma, disease, or congenital defects. And these scaffolds serve as framework that mimic the natural extracellular matrix of bones, providing suitable environments for the attachment, proliferations, and the differentiations of cells. And these scaffolds are typically made from biocompatible materials and that can be tailored in terms of their porosity, the mechanical properties, and the bioactivity to encourage the formation of new bone tissues. So previously, most of the researcher focus on their productions, the fabrication, the manufacturing process, the materials, and so on. But they have lack of the environmental impacts or sustainability impacts, especially on the carbon footprints, on the acidification, and also the eutrophications. But this study, we focus on the carbon footprints So what is the carbon footprints? So carbon footprints measure the total greenhouse gas emissions and particularly carbon dioxide that produced directly and indirectly by human activities. And the carbon footprint is the sum of all emissions of carbon dioxide which are induced by activities in a given time frames. And it's usually calculated for time period of a year, or actually it depend on the research system boundary or depend on the requirement of the clients. And other than carbon dioxide, we focus on the methanes and also the carbon monoxide, which contribute to the carbon dioxide equivalents, kilograms. Okay. So this slide show the carbon footprints and the relevance to the tissues engineering. So in tissue engineering, the carbon footprints encompass the environmental impact of various processes that involve in scaffold fabrications, the cell culturing, and also the tissues growth. And this include the energy consumptions, the raw material extractions, the transportation, and the waste generations. We need to understand and reduce the carbon footprints associated with the tissue engineering is crucial to align the field with the sustainable practice. So minimizing emissions that can lower the environmental burdens of research and healthcare and making strides towards a greener and more responsible approach to regenerative medicines. And this involves optimizing the manufacturing techniques, utilizing the eco-friendly materials, and adopting the energy-efficient process to reduce the overall environmental impact of tissues engineering procedures. So this slide shows the carbon footprint and its relation to environmental impacts. So as mentioned before, the carbon footprint emitted directly and indirectly due to human activities. Every day we produce the carbons, and these emissions contribute to the global warming and climate change by trapping heat in the Earth's atmosphere. And the carbon footprint encompasses various aspects of human life, including energy consumptions, the transportation between material, the extraction of material to the production, warehouse, and so on. And the carbon footprint is directly related to environmental impact because greenhouse gas emission are significant driver of the climate change. And the higher level of these gases in the atmosphere lead to increased temperature, altered the weather patterns, may rising the sea levels and other environmental disruptions. And thus, by reducing the carbon footprints, is essential for mitigating the negative effect of climate change and preserving the health of ecosystem. So this is the importance of sustainable practice in medical and scientific research. First, to ensure the responsible use of the resources, minimizing waste and environmental impacts. And secondly is to sustainable foster long-term viability, allowing research and healthcare advancement to continue benefiting the society without depleting the resources. And lastly is the ethical considerations comes into play as the sustainable practice help the safeguard and well-being of present and future generation by preserving the ecosystem and maintaining a healthy environment. So this research focus on this SDG, Sustainable Development Goals, number 12, which is the responsible consumption and productions. We focus on the environmental impacts, which is to achieve the sustainable management resources, such as developing a tools or methodology to monitor the sustainability impacts. So this is the methodology for environmental evaluations. We use the life cycle assessment LCA by using Gabi software, and we referring the ISO 14040 specifically for LCA for environmental impacts. And the manufacturing process that produce 3D bone tissue engineering is characterized by heavily energy use. 3D printing technology utilizing heat or laser that more than conventional production methods to produce the product parts or objects. And the use of chemical to melt or bind the particle in the 3D printing technology may result in the waste potential that also can be harmful to the environments. And since the material and energy use will have the negative impact of the environment, It is essential to list the opportunities to improve the environmental sustainability of productions process for 3D bone tissue engineering scaffold. So this is the system boundary of LCA. So in LCA, we have many system boundary, but previously we focused only gate-to-gate system boundary, which is focused on the material and the fabrication of the 3D bone tissues. In future, we want to widen our system boundary, which considering from cradle to grave, which is considering the extraction of the materials consumptions, and the fabrication process, include the assembly, retail usage, and lastly, we will consider the end of life management, which is we can recycle or we can remanufacture of the products. Okay, so this is the development of LCA model by using the Gabi software. As you can see at the left, this is the material used to premix, and then we premix until we got the slurry types. These materials comes from the literature review, and then after we got the slurry types, and we can move to the 3D printing process lah to get the scaffold fabrication that consume electricity and also heat temperature for the sintering process. After construct the LCA model, and then we can calculate the results by percentage of the by kilogram of the carbon contents. Okay, in LCA, in this study, we focus on the 4 potential environmental impact, and the first, of course, the global warming potentials. So what is the GWP? Okay, global warming is an environmental impact that responsible for greenhouse gases emission into the atmosphere, and the kilogram of carbon dioxide equivalent is consists of the carbon dioxide itself, the carbon monoxides, and also the methanes. And secondly is for acidifications. Acidification is commonly the second most heavily environmental impact that has been evaluated in many researchers in the literature, which measure the kilogram sulfur dioxide equivalent emissions, and this consists of the sulfur dioxides, nitrogen monoxides, and also the nitrogen oxides. Third is the HTP, which is the human toxicity potential, that calculate the index that quantify the potential harms of molecule of chemical release into the atmosphere, and based on the inherent toxicity and its potential flows. And this HTP focus on the NMVOC, which is the non-methane hydrocarbons, emission of dust and heavy metals. And lastly, we focus on the eutrophication potentials, that is the negative environmental impact of the responsible of nutrient enrichment in soil or water. And EP comes from the phosphorus, the biochemical oxygen demands, chemical oxygen demands, and lastly the ammonia. So from the after constructing the LCA model, and then we calculate the potential environmental impact by using the material from the literature review, and then we obtain the results. Okay, so this is the results of the potential environmental impact for 3D bone tissue engineering scaffolds. As you can see from this graph, the scaffold fabrication contribute 3.8 kilogram carbon dioxide equivalents for 1 year, right? So we can total it, or it actually depends on what client wants. Okay, if they want to know only the carbon content for the fabrication process, so we can calculate just for the process based on the system boundary chosen. Right. So this slide show the importance of the material selection in reducing the carbon footprints. Okay, the type of material used directly influence the environmental impact throughout the entire life cycle of the scaffolds, from the raw material extraction to the production, use, and also the disposal at their end of life. Okay, by choosing the materials with the lower energy intensive production process, renewable sourcing, and minimal waste generations, researcher and manufacturer can significantly decrease the carbon emissions associated with the scaffold fabrications. For example, if the researcher choose the ceramics, so they need to list the potential environmental impact, the advantage, and also the considerations. For example, the ceramics materials are often derived from minerals, and their production can involve energy-intensive process. However, they offer long-term stability and biocompatibility. The advantage of ceramics is closely resemble the mineral composition of natural bones and promoting integration with host tissues. And the considerations is the energy intensive nature of ceramic production should be balanced with their durability and potential for long-term use. So the importance of manufacturing selections in reducing the carbon footprints. So manufacturing selection involves the choosing the more suitable and sustainable method to produce goods and materials. And the decisions directly impact resource consumptions, energy use, the waste generation, and overall the environmental impacts. And the importance of manufacturing selection in reducing the carbon footprints in 3D bone tissue engineering scaffold is significantly due to its direct impact of environmental sustainability, the resource conservation, and also the responsible healthcare practice. By opting for manufacturing methods with lower energy requirements and more efficient material usage can significantly reduce the carbon footprints, which is contributing to the global effort to reduce the climate change. So this is the conclusions. We need to, the challenge is to balance between the environmental considerations, the medical requirements, and also the patient safety. As for environmental considerations, we need to strive for the reduced carbon footprint that should align with broader environmental considerations. And by implementing the sustainable practice, the healthcare industry can contribute positively to environmental preservations. As for medical requirements, by adopting the sustainable materials, it's crucial to ensure that the material maintain the necessary mechanical, biological, and biocompatible properties for successful tissue engineering. And lastly, for safety, so any change in material or manufacturing process must undergo testing and regulatory approval to ensure that they meet the safety standards. Okay, so this is the several publications during the research. Actually, this research is still continue. We currently focus on the different type of the material use. So for this opportunity, I want to thank you to grants provided from CRG UTM National 2019 on title Life Cycle Assessment of 3D Bone Tissue Engineering Scaffold, and also the F22 on title A New Methodology for Assessing the Sustainability of 3D Bone Tissue Engineering Scaffold using Fuzzy Logic Approach and AHP methods. I want to thanks to Dr. Hasrul from UTM, Prof. Zamri, and also Prof. Safian for contributing their idea in this project. And lastly, but not least, our precious student Nurul Ainina and Farah Shafinas that contribute also to these projects. So I think that's all from me. Thank you. So any questions? I'll stop the slides. Okay, thank you for the questions. So, currently we focus on the material from the literature review, but our focus is on the material and also until the production process, which is only gate to gate system boundary. But we works on the wide system boundary, which will consider the cradle to grave. Then we can study if the recycled material can can use as the material for the 3D bone tissues. But for your informations, my team and me, we focus only on the environmental impacts. But the material selections, the type of materials we got it from the another researchers from UTM. Thank you. Are there any challenges associated? I think are there any challenges associated with their implementations? So currently we don't have any recycled materials used, but we, as I mentioned previously, we focus on the material from another researcher, but it's confidential. It's still confidential state. Okay, then we will collaborate more to get the environmental impact based on the new material proposed by Dr. Hasrul and team. Okay, so
Thank you,
any
Dr.
other questions?
If there are no other questions, I would like to thank you, Dr. Salwa, for sharing the wonderful research.
All right.
Now, I would like to pass on the session to our next chair.
Okay, good morning. Assalamualaikum warahmatullahi wabarakatuh. Yeah, and the voice not.
Can you hear?
Yeah.
Assalamualaikum. Good morning. Selamat pagi. Magandang
Selamat
umaga.
pagi.
I am Nura Shafira, and I will be
Yes.
chairing this session of the International Symposium on Medical Devices and Technology. Speaking on behalf of the organizing team, I would like to extend our most welcome to all participants and also to our esteemed speakers who will generously impart their expertise during this session. Without further ado, let us welcome our first speaker, Professor Dr. Suryani Diah Astuti from Universitas Airlangga, Indonesia. Professor Suryani, the virtual floor is now yours.
Okay, thank you so much. I would like to share our presentation. I'm sorry, I am not familiar with WebEx.
It's okay, Prof. Can take your time.
Okay. Ah. I'm not
Hi,
yet
Prof. May
open.
I assist you?
Yeah. I not yet open my.
All right. Beside
Yeah.
the start video button, have a share button.
Yes. I must open the system preference. I don't know why.
System preference.
Yeah. Open system preference to allow webpack to share your content. I don't know what this.
Prof, just
Yeah.
click the share button.
Save
Then
button.
click share.
Yeah. Share. Yeah. I click the share and open system preference.
Okay, click open.
Yeah. Open. And then
Is there have any menu on the slide presentation or screen?
presentation or screen. Nothing. Privacy and security.
Okay, Prof. Just email your slide to me. I will
Okay.
share.
Okay.
All right.
Okay.
I will put
Okay.
my
I will.
email on the chat box.
Okay. I'm sorry. I already sent the file presentation. I already sent.
Okay, Prof. Now I'm waiting to receive the file.
Okay.
Prof, I'm sorry. Can you forward the email to the new email? Because I did not receive it.
Yeah. I already sent the email.
Yeah, just forward on the new email as mentioned in the chat box.
Oh, yeah. Okay, I send more.
Yeah, to Nurul Shafira.
Yeah.
Sorry, Prof, we still do not receive that. Can you forward that at Dr. RD email?
Oh, WA,
Oh, WhatsApp,
maybe
WhatsApp.
WA.
WA, yeah.
Okay. Already sent to Dr. Ardi. Already received?
Yes, Prof.
Yeah.
Now we're opening.
Yeah. Okay. Assalamualaikum warahmatullahi wabarakatuh. Thank you, ladies and gentlemen, for the time for we to present our research about dental laser photonic-based therapy for dental and oral disease. I am Suryani Dia Astuti, and our researcher team from Airlangga University. We are from many other faculty to produce a new innovation device for medicine that are a dental laser. Dental laser is a device for therapy of the dentist and skin based on of laser diode. Next. Yes, this is on the outline of our presentation. Next. Yes, we will present about PDT, the mechanism of PDT, dental laser, and product improvement and market analysis. Next. As background, we know if the dental and oral disease occupied 10 disease, the people complain and its prevalence increases from year to year. In Indonesia, at 2013, about 25.9%, and it increasing. Next. at 2018 about 57.6%. So next, there are many types of treatment for teeth extraction that are alveolar osteitis, dry socket, gingivectomy, and also antibiotic. So the consequence of this treatment are next. Lymphadenitis. No. Before lymphadenitis, infected molar, bacteremia, and also antibiotic resistant. So we are offer the new curative effort method based on photodynamic therapy that are antimicrobial and photobiomodulation with a dental laser. Dental laser uses lights and a photosensitizer to produce a free radical, and this free radical can inactivate microbia infection. Next. So the photodynamic therapy based on of photodynamic inactivation. What is the photodynamic inactivation? Is a therapy method using light and photosensitizer that are the non-toxic molecule. And this PDA mechanism start from absorption of light energy by photosensitizer that are corresponding with a wavelength and absorbance. Next. Now, to get the effectiveness of PDA, compatibility of the spectrum of light source used with the absorption spectrum of a photosensitizer. Yeah. There are various photosensitizer can decrease the viability of bacterial resistance of antibiotic. The photosensitizer is a light-sensitive substance that plays a role in the absorption of energy light in PDI. Yeah. There are many endogenous photosensitizer and exogenous photosensitizer, like porphyrin and the other chlorophyll of as exogenous photosensitizer that are the mechanism of a photodynamic therapy. Next. Endogenous photosensitizer is like porphyrin. There are many types of porphyrin that are coporphyrin 1, coporphyrin 3, and protoporphyrin 9. Yeah, that porphyrin with absorption peak at a red band that are in visible light. Yeah, in the region of blue to red invisible light. Next. And a laser is a light amplification by stimulated emission of radiation. With the properties of laser is a unidirectional, monochromatic, and a coherence. Yeah. There are many types of laser can affect the penetration depth of the laser in the skin. Yeah. This is from blue to red and infrared of the spectrum of laser. Next. The laser tissue interaction in the skin, that are many types of the interaction. And the first is biostimulation, and then photochemical mode and thermal mode included evaporation and coagulation, ablation, and electromechanical mode. In this photodynamic therapy, we use photobiomodulation and photochemical mode that are safe for patient. Yeah. Next. So the mechanism photosensitization of photodynamic therapy is the absorption of light by the photosensitizer molecule that further activate the photochemical reaction produces a wide range of reactive oxygen species. Next. There are three many types of mechanism photosensitization that are photophysics, photochemistry, and photobiology. Next. Photophysics is the first step of absorption of photon energy that are the excitation of molecule. Yeah, the photophysics mechanism can be explained by a Jablonski diagram, like this are the mechanism of physics and the photodynamic therapy. Next. After photophysics, the second mechanism is a photochemistry. That are two types of photochemistry reaction. Type 1 is involve a hydrogen atom abstraction of electron between the excited sensitizer and substrate, yielding free radical. This free radical can react with oxygen to form an activated oxygen species as the superoxide radical anion. And the second type is the singlet oxygen is generated via an energy transfer process during a collision of the excited sensitizer with triplet oxygen. Please next for the photochemistry type 2. Please next. Yes, this is the photochemistry type 2 that the photochemistry reaction can produce the many type of radical oxygen species. And next. This is the mechanism of photochemistry with reaction Haber-Weiss. Yeah. And the produce to hydroxyl radical is diffused through in the membrane and cause of cell damage of the microbacterial membrane. Next. And then the mechanism of photobiology, the ROS, can damage the cytoplasmic membrane, allowing leakage of cellular contents or inactivation of membrane transport system and enzyme, and that cause peroxidation and lipid and membrane protein. This is the type 1 of photochemistry, and this is the type 2 of photochemistry. So, the effect of a ROS can be damaged in the membrane of cell bacteria. Next. This is the bacteria cell wall. 90% of singlet oxygen can react the cell lipid bilayer and protein associated with the membrane transport system, lipid and protein peroxidation, and cause damage of the cytoplasmic membrane and also protein. So that is the lysis cell and the bacteria can damage. Next. And then the second mechanism is a photobiomodulation. Photobiomodulation is a non-thermal method that utilizes a light rays and the visible and infrared at a low power of the laser diode. So the photobiomodulation therapy is more safe and effective for the regeneration cell and accelerate for wound healing in the skin. Next. This is the photobiomodulation mechanism. The administration of photobiomodulation therapy can increase the mitochondrial respiratory chain activity and increase the ATP level in brain tissue and releasing NO, ROS, and intracellular calcium, which cause a wound healing and prevent tissue death by activating transcription factor, anti-apoptotic, antioxidant, and also proliferative gain products. Yeah, that is the mechanism of photobiomodulation. Next. Okay. That is the dentalizer innovation. Dentalizer is a medical device based on the antimicrobial and photobiomodulation to accelerate the dental on oral disease healing response with advantage that device are non-invasive, effective, safe, and cheap. Next, there are many phases of the improvement of dental laser at 2014, and this is the first dental laser with research funding for DRPM and CPPT, and that the second for photobiomodulation with research funding of innovation and matching fund, and the latest version is a dental laser with research funding and matching fund. That is the specification of dental laser. And the dental laser, we use two probe of laser, blue spectrum and a red spectrum for antimicrobial and photobiomodulation. That on the blue spectrum is about 405 nanometer, and the red is 950 nanometer with fiber bundle 8 millimeter. And the effective laser power is 50 milliwatt, and the energy of use is 1 joule per centimeter square. Next. Yeah. Dental laser is the new product, uses a local raw material, and so the selling price is cheaper, and this device can be used by dentistry, student, and public for antimicrobial therapy and photobiomodulation, and also for dermatologists and acupuncturists for therapy and research. Next. The social impact of a dental laser is purchasing medical equipment, especially for a dental and oral disease with good performance and affordable price. And the economic impact, the cost of treatment is more affordable by the community. Next. This is the production and product flow of Airlangga University Teaching Industry and Sarandi Karya Nugraha Company. We collaborate with Sarandi Karya Nugraha Company to produce the dental laser. So in Airlangga Teaching Industry, we use research and development and electronic manufacturing. Yeah. And the Sarandi Karya Nugraha, they produce material production, casing, and assembling and finishing. Okay, next. This is the mechanism production and testing. Next. This is the production in Sarandi Karya Nugraha, and we also teaching by MBKM, Merdeka Belajar Kampus Merdeka in Indonesia, and we education to user. This is the product, the latest product, and next. This is the pattern of dental laser, the version 1, version 2, and the latest version. And next. And this product certified in the e-catalog. Next, and we have two books for the guide of this product. This is dental laser. And next. So we collaborate the Airlangga University Teaching Industry with Sarandi Karya Nugraha Company partnership in the produce bill of material planning and the submission and a renewal of production permit and medical devices distribution permit, and the student learn in the industry, and the product device master file design, and preparation of supporting production line, and the preparation of SOP and product testing standard. Next. This is the tinto laser marketing mix. We improve the product improvement for antimicrobial and photobiomodulation, and we complete the domestic component level before selling to health agency, and the price start of launch is at twice of cost of goods sold, and then the promotion, we use digital marketing, branding, communities and trial program, and the place distribution system that run conventional direct selling and online selling. Next. This is the certification product of Dento Laser. This is in catalog. The price of Dento Laser is about $900 US. Next. This is the link of our YouTube for the product of Dento Laser. We can look the clinical trial and the production process and the certify of the Dento Laser and the product of NAE catalog. Next. Okay, that is our presentation. Thank you very much for the time of presentation. Maybe we will discuss about our product and our research. Thank you so much. I'm sorry, I listen.
Thank you, Professor, for the enlightening sharing. So we are now at the question and answer session. We have two questions from Irfan Naufal. The first question is there any risk when using photonic-based therapy for dental treatments, and how to address those risks?
And how to address
those risks?
Okay, yeah. There are two treatments for antimicrobial infection, for photobiomodulation to accelerate wound healing after operation and after the dental extraction. The dose of 1 joule per centimeter square. So the time of treatment is about 30 to 50 seconds for one teeth. Yeah, 30 to 50 seconds. Yeah, for one teeth. So if the Dento laser with a laser diode and the lifetime, if 5,000 to 10,000 hours, yeah, 5,000 to 10,000 hours. So we use one patient and one teeth is about 30 or 50 seconds. So I think it's very effective and very cheap. Thank you.
For the second question, is dental laser effective considering factors such as cost and long-term maintenance?
Yeah. I already test. Yeah, I already test the dental laser with lifetime 5,000 to 10,000, and for the clinical trial for periodontist, endodontist, and also teeth extraction with 1 joule per centimeter second can effective to accelerating the wound healing in the teeth. Yeah. Okay.
Okay, I think that's all for the questions that we have. Thank you, Professor, for being part of this symposium. And we look forward for more discussion in the next time. Have a wonderful day ahead, Professor. Assalamualaikum. Thank you.
Okay, thank you so much. I'm sorry if there are trouble with the connection and our WebEx computer. I'm sorry if there are many discussion. Please contact for me by email or by WhatsApp group. Thank you so much.
Okay, thank you.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Okay. Okay, dear viewers, our journey through this symposium continues, and it's now time to introduce our next speakers, Dr. Ma Luisa D. Enriquez from De La Salle University, Philippines. Dr. Ma, the floor is now yours.
Hello, good morning. Can you see my slide?
Yes, Dr. Enriquez.
And wait,
Sorry, doctor. This
the
one is
sound is okay.
the sound is okay, but the slide is not in the slideshow mode.
Oh. How about that?
Okay, this one okay. Yeah.
Okay.
Thank you, doctor.
So good morning, everyone, and thank you for the invitation to talk in your conference. And unlike the previous speaker, I'm not going to talk about a research. It's actually a laboratory facility to describe the journey of the science of cytogenetics through this year. So my title was Human Cytogenetic Technologies Past, Present, and Future. But we will focus on cytogenetics from using the microscope to the computer and beyond. I am speaking in behalf of two institutions, primarily the St. Luke's Medical Center, my lab, the Molecular Cytogenetics Lab, and of course, I also teach at the De La Salle University. So cytogenetics, I think we are aware, many of us know, is a branch of genetics that studies the chromosome, their structure and function. They are actually linear or condensed form of our chromatin fibers. And at metaphase, they are highly condensed, so we can see them under the microscope. And they are the structures that carries our genes. And on the right side of the slide, you will see that these are solidly stained metaphase chromosomes, and they are well spread. And in the normal karyotype, we have 46XX or effort for the female and 46XY for the male. Going back through history, the present karyotype was identified by two scientists in 1956, Joe and Levan, using culturing blood lymphocytes from an embryonic lung. Eventually, the technique was improved by the discovery of culturing method and various banding technologies. So today, when we talk about cytogenetic technology, it's really a set of methods built from scientific knowledge and is used to achieve specific goals or solve a particular problem. So we have two major applications now to establish the genetic basis of constitutional or classical syndromes and the use of this technology in the diagnosis, treatment, and management of human diseases, particularly cancer. So in the lab, we accept samples, either they are peripheral blood or bone marrow aspirate from malignant patients with malignant diseases. And these are cultured using a variety of chemicals, and they are stored in the incubator supplied with CO2. at 37 degrees. If we are culturing a normal or a peripheral blood, we incubate them for 72 hours. If it is a bone marrow aspirate from leukemia patient, we incubate them for 24 to 48 hours. After that, we harvest the chromosomes. We do the slide preparation, stain, and we look at the structures on the left side for analysis. Today, the global market for cell culture is quite big. No? In 2022, they reported 19 million US dollars, and this industry is expected to grow by 7.2% until the next few years. So, sorry about that. As I mentioned, we go into the journey of cytogenetics as a technology. Before we opened, when we opened our lab in 1995, we do the karyotyping analysis by manual technology. So we do, we capture the images using a camera, develop the negative inside the dark room, and cut the chromosomes individually before they are laid down to a particular form. Now we have an automated cytogenetics workstation, which has a digital imaging system, an automated slide loader, and a automated metaphase analysis. Nevertheless, the cytogeneticist is still needed to check the output of the automated system. So this whole development in the technology really cut the time in terms of turnaround time for the results to be given to the doctors and patients. So based on this development, we can now see beautiful images of metaphase chromosome. And this is, of course, the normal male, and this is a normal female. If you can see, they have different levels of condensation based on that stage of the metaphase cells by which they are arrested. So from these normal karyograms, we can now spot the abnormal chromosomes. So just a short journey to history. The most common type of genetic disorder is Down syndrome. And it was Lejeune who discovered this among his patients, and he found an extra chromosome 21 in this group of patients. We have, since it is a syndrome, we have a collection of clinical features in Down syndrome, which I think everybody is familiar with. The other classical syndromes we see in the lab are Edwards syndrome, a Klinefelter syndrome, and Turner syndrome. So in Edwards syndrome, well, usually this is the child does not grow older in a few weeks or months, the child dies. And of course, here is male, but presents female characteristics. And this is Turner syndrome, usually characterized by small stature and other clinical features. In the lab, we also do cytogenetic analysis of, as I mentioned, constitutional karyotype. And the most common we have are Down syndrome cases. And there are the classical Down, and of course, there are mosaic type of Down syndrome cases. Moving forward, the study of chromosomes was later on applied to cancer. And the first scientist who discovered the first abnormality in cancer is Peter Nowell of the University of Pennsylvania and David Hungerford of the Fox Chase Genetics Lab. Nowell was an employee of the Navy, the US Navy. And in his experiments, he saw a very unusual small chromosome in the blood of chronic myelogenous of leukemia patients. And with the help of David Hungerford, they were able to identify that the unusually small chromosome was chromosome 22. But it was a few years later that Janet Rowley identified that it was not a deletion of chromosome 22, but a translocation between chromosome 9 and chromosome 22. So today, leukemia patients are screened initially for the presence of this abnormality, chromosome 9 and 22. So as you can see here, abnormal 9 is longer and chromosome abnormal 22 is shorter. So why is this very important? Before any drug is given to a patient, a leukemia patient, specifically the chronic myelogenous leukemia, this schematic diagram here shows the ABL gene, which resides on chromosome 9, and the BCR gene, which resides on chromosome 22. And during the translocation process, your BCR-ABL fusion occurs in chromosome 22, and this is supposedly known as the pathogenic translocation on chromosome 22, which dictates the leukemia disease. So, aside from the initial slide smear being analyzed by the doctor when a patient goes to the hospital, when the doctor sees this kind of clinical presentation, then they are required to do cytogenetic analysis to establish the 922 translocation. Why is this very important? Because this work of Janet Rowley actually pioneered what is now called the translational medicine. And in 2010, they celebrated the 50 years of the Philadelphia Chromosome Symposium. By the way, it's called Philadelphia Chromosome because the discovery was happened in the state of Philadelphia. So today, this translocation has paved the way for a particular drug to be used for patients who carries this particular translocation abnormality. So the drug targets specific gene mutation. It's not a chemo drug, it's a molecularly targeted drug. And in 2001, it has been the cover of Time magazine, and it was heralded as one of the major breakthroughs of the century because it was able to cure a large number of patients having CML. So the drug is called imatinib or Gleevec, and the main job of Gleevec is actually to compete with the binding site of the ABL gene. So your ABL gene cannot bind to your BCR. Therefore, the fusion gene is not formed. Therefore, the abnormal protein is not produced. So imatinib or Gleevec is the first-line drug for treatment of chronic myelogenous leukemia, and it stops the progression of CML. But the sad reality, after so many years, they found out that leukemia cells are very intelligent. They were able to mutate the binding site of imatinib, and in some cases, in some patients, the drug gives rise to resistance. But of course, that's another story to tell. So in our lab, we diagnose both CML and ALL, and it's now established that certain cytogenetic results actually gives the doctor an insight which of the patient will have favorable prognosis or poor prognosis. So these are the list of abnormal karyotype that will tell the doctor that this patient will have favorable prognosis and these patients will have poor prognosis. So while cytogenetics seems to be a very, very good technology, it has its own limitations. Cytogenetics can only be done if you have a dividing cell. And for this, we need fresh sample. So we cannot use paraffin blocks of cancer patients. We need fresh sample, be they peripheral blood or bone marrow aspirates for leukemia patients. And also you need the cells to divide. Even if you culture them, if they don't respond to the mitogen or they don't respond to the culture conditions, cytogenetics cannot be done. So you have to have a fresh tissue. The fresh tissue has to be cultured. The cultured cells will have to divide to yield this metaphase chromosome. And not only that, it should be good chromosomes with good morphology, and the resolution should be adequate for analysis. The limit of resolution for G banding is about 5 megabase. So if the cells do not divide, chromosome analysis cannot be done. So to address these limitations of the routine karyotyping, another technology has been introduced, and this is called fluorescence in situ hybridization, or in short, FISH. So this is a powerful technique in tandem with the routine chromosomal analysis. It was introduced in the 1980s, and it refined increase the level of cytogenetic screening. It has a very high specificity and sensitivity. It reduces our turnaround time. And the most important thing, it can be used both in non-dividing and dividing cell. So, but you have to have a fluorescence microscope to be able to do this, as well as fluorescence probe. So this is a very detailed view of what a fluorescence microscope, and this is the fluorescence process, which I did not have time to explain, but of course you need filters here to allow certain wavelength of light to enter that can give you that can make you see the probes in particular colors. So the probes can either color your entire chromosome, it can color only the centromere, it can color the telomere, or it can color a specific gene. So in short, your chromosomes, your target are on the slides, and you put in the probes. Your target are double-stranded DNA. Your probes are also double-stranded DNA. You have to denature both the probe and the slide and the sample, so that when they are single-stranded, they can hybridize in this particular step here. With your probe, you know if your probe has labeled your target. And when the light is shown, that means that's a positive hybridization of your probe into the target. So in the BCR-ABL, the probe for BCR is usually colored green, and the probe for ABL is usually colored red or orange. And when they hybridize, the color yellow is produced. So in fish, whether you do it at interphase fish or metaphase fish, you know there's a fusion of the BCR-ABL gene, which reflects the translocation between 9 and 22 if you see the color yellow in your dual color, dual fusion probes. So this is the interphase fish. On the right, you will see the normal cells because there is no fusion. There's no yellow signal. On the left, you will see the fusion signals indicating the reciprocal translocation between chromosome 9 ABL gene and chromosome 22 BCR gene. So these are all positive for CML. These are actual images from the lab. There is another complication in routine chromosomal analysis if you have a complex type of karyotype. Complex meaning to say you have 3 or more abnormalities, and because you have just the gray, black, and white banding technology, chromosomes that are complex are usually not easily analyzed in the lab. So a new technology has been, of course, as I mentioned earlier, the whole chromosome paint. So this time, the chromosomes are painted with specific colors. And this is an image from our recently published work in December 2022. We presented 4 cases of leukemia with complex karyotype. And as you can see, we have a translocation here between 3 and 20. And we have also a 9 and 22 type of translocation. So while this is a CML patient, he carries another set of translocation between 3 and 20. Now, what is the significance of detecting complex karyotype? In leukemia, patients with complex karyotype have poor prognosis. So in the lab, these are our 2 imaging systems. The applied spectral imaging, ASI is the imaging system here. We have an Olympus microscope, and we have a Metasys as well. And the microscope here is a Zeiss. So these are both automated type of imaging system. But technology continues to improve. Now, ASI has came up with a new features. You can load as much as 99 slides here. And it is an automated loading system as well. The softwares are now have a faster capturing mechanism, just in times of a few minutes. And you can load more slides. It has higher resolution. It has a faster metaphase analysis. And also the fish has an automated analysis. Moving forward, there's another technology called comparative genomic hybridization. And in this technology, as we go to the DNA level, This is applicable in cancer patients. You have here a tumor DNA from the patient, and you have a normal DNA for the reference genome, and these DNA are now hybridized into a normal metaphase chromosome. Usually this is an XY karyotype. The sample is an XY. And as they are hybridized, the tumor DNA is labeled with a green fluorescence dye. The normal DNA is labeled with a red fluorescence dye. They are hybridized into the chromosome and they will show signal. So the amplification will show if you have more green, then you have more gains in the chromosome, genes along your chromosomes. And if you have mixed green and red, you will have more or less an even ratio. More higher in terms of technology is the array comparative hybridization, which is an improvement of the previous CGH. And in this case, it's basically the same. You have your probe on the slide, and you have and your sample is the one put onto your slide. Unlike the fish, it is your target that is on the slide, and you put the probe on top of it. So in CGH, you have your probe fixed on the slide, and you have your samples put onto the slides. And in this case, you have not only the chromosomes, but also the genes are now amplified, either over expression or under expression. So it provides a genome-wide high-resolution scale, not only the chromosomes per se, but the genes as well. So it has an image analyze software and as a scanning software as well. So this is a summary of the array CGH where you extract and label your DNA, you wash, you hybridize and wash, you scan, and you analyze your data. And unlike the previous one, the entire length of the chromosome is analyzed. Very recently, there's a new technology slowly gaining momentum. This is called the optical genome mapping. And again, this is much higher than the array CGH. And this is a genome-wide technology that can reveal both structural genomic variations and copy number variations in a single assay. So the technique actually also needs a genomic DNA obtained from your cells, and they are sheared, and they are fixed into a substrate, and they are stretched. Your DNA is stretched, and using restriction enzymes, your DNA are cut, and each of this segment is sequenced. So the DNA fragments actually are stained with the intercalating dye, which are fluorescent intercalating dye, and are also visualized using a fluorescence microscope. So each of these fragments are actually producing an optical map, and this optical map are synthesized together to create the map of the entire genome. So this is the summary of the OGM workflow. Hopefully, St. Luke's Medical Center may be able also to purchase the system, if not late this year, early next year. So this OGM can address a large body of researches. In the Philippines, we have so many children with autism or developmental disorders whose karyotype are seen to be normal. But we know that the genome carries abnormalities, and we look forward using OGM to be able to diagnose diseases that are beyond, that cannot be analyzed by the routine karyotyping technology. So in summary, the cytogenetics as a technology has evolved from its classical use to its modern use. From the routine G-banding karyotyping, it has paved the way for the new technologies such as FISH, CGH, array CGH, optical genome mapping to flourish in this modern era. So may I just add, these are the services offered by the Molecular Cyto Lab of St. Luke's Medical Center. We have been in operation since 1995. And this is a 2020 data of what kind of patients we do in the lab and what kind of samples have been are requested so that these assays can be done on the samples. So with that, I would like to thank you for listening. This is an old slide of my students who have been with me and have actually moved on. Many of them are PhDs now and working in the different parts of the world. Thank you very much.
Salamat po, Dr. Enriquez. We now come to question and answer session. We open the question and answer session to the participants. Okay, we have one question from Aisha Mualif. Hi, Dr. Luisa. Thank you for your great sharing. For imatinib drug, can it be used for other type of cancer other than CML? For autism, is it possible to be detected during pregnancy?
Yes. Thank you for that question. We do amniotic analysis in the lab. So, and also products of conception. So we can culture amniotic cells, but of course it will be the doctor who will do the extraction for you. We also do products of conception. We have a good number of patients who had multiple spontaneous abortions. So the aborted materials are actually catch early. There is a plan for that. The product of conception, whether it's the fetus or the chorionic villi, you have to follow a certain protocol. It can be brought to the lab. A small amount of the fetal tissue, they can be cultured. So I did not have time to present. We have many chromosomal abnormalities in amniotic fluid, using amniotic fluid, and at the same time from fetuses, products of conception. And of course, it can be used in other types of cancer as well, from acute leukemia, as I mentioned, from lymphoma as well, and from solid tumors. I hope I answered the question.
We have second question. Beside leukemia, is there another of cancer that have been studied based on cytogenetics?
Yes, we have ALL, acute lymphocytic leukemia, and we have APL, acute promyelocytic leukemia. Usually you have 15-17 translocation. We have also detected number 16 inversion. And as I mentioned, we have all sorts of leukemia, not only CML, but also ALL and AML. So acute lymphocytic and acute myelocytic leukemia.
Okay, doctor. That's all for the question. Okay, thank you for the different participants from the viewers and also the insightful answers from Dr. Enriquez. We have now come to the end of this session. Again, we would like to thank Dr. Enriquez for your willingness to share your knowledge. This has made this symposium a platform for meaningful knowledge exchange in medical devices and technology field. Thank you, Doctor.
Thank you.
Now I would like to pass the session to Alfan Haider for the next session.
Hello, Assalamualaikum everyone. Am I audible? Okay, thank you. Welcome once again and very good morning once again to all of you. I am Arfan Haider, the presenter, the uh, your chairperson of this session. So now without further ado, I would like to invite our next presenter. The next presenter is Datu Professor Dr. Muhammad Rafiq bin Datu Abdul Qadir. He is from University Himalaya. Welcome, Professor, once again. So over to you, flows for you. Thank you. Prof, can you open your mic? Sorry.
Thank you, Arfan.
You're welcome.
Right, let me share my slides. Where is my slides? Can you see my slide?
Yes.
Arfan, can you see my slide?
Yes, slides is appearing, but it's white. Nothing is written. It's empty. Now, yes, it's look.
All right, okay. Is it full screen now?
It's full screen.
Full screen. All right, okay. Right. Bismillahirrahmanirrahim. Alhamdulillah Rabbil Alamin. Wassalatu wassalamu ala ashrafil anbiya wal mursalin. Wa ala alihi wa sahbihi ajma'in. Rabbi shrah li sadri wa yassir li amri. Wahlul 'uqdatam min lisani yafqahu qawli. Rabbi zidni ilma. Rabbi yassir wa la tu'assir wa tammim bil khair. Allahumma la sahla illa ma ja'altahu sahla. Wa anta taj'alul hazna idha syi'ta sahla. اللهم إني ضعيف فقوي في رضاك ضعفي وخذ إلى الخير بناصيتي واجعل الإسلام منتهى رضايا اللهم إني ضعيف فقويني وذليل فأعزني وفقير فأغنني وارزقني. First of all, I would like to say thank you to the organizing committee of Symposium MEDiTEC for inviting me to give a few things regarding the kind of research work that I do. This is basically it, yeah. And before I start, the only thing that I can see on my screen right now is my PowerPoint presentation. So, Arfan, if there is any problem, then you should let me know, yeah, because I cannot see anything else other than my full screen, which is currently my slide. All right, okay. Right, mechanics and materials. I've been working on mechanics and materials for a very long time, since the year 2001, if I'm not mistaken. So it's been 22 years already. And the kind of work that I do, I basically can be categorized into two major things. The first part is mechanics, and the second one is materials. Rather than choosing one particular topic for me to discuss today, I will just go through an overview of the kind of work that I've been carried out with my students. Yeah, so just one slide, one project, if you like, rather than discussing on one particular project. Because for this symposium, I think it would be better if I give an overview of the kind of work that I do, rather than concentrate on one particular topic. That would be rather very dry topic. Yeah? So the contents for this presentation is going to be just two parts. The first one is related to mechanics, and the second part will relate to materials. And this is the center which we started as a research group back in 2006. in medical implants and devices. And the one who is sitting on my right in that picture, the one sitting on my right is Associate Prof. Dr. Ardian Shah, who is the first director, for MEDiTEC. Yeah. So we set up this group in medical implants and devices back in 2006. And Alhamdulillah, we managed to upgrade that research group into a center of excellence. And the first director is Ardi. So hopefully, Ardi, you are listening to this presentation. Right. Okay. So what do we do at MEDiTEC since 2001 or maybe 2005? 2005, because my PhD work was on hip arthroplasty, which relates to biomechanics and biomaterials. But since 2005, when we started the research group, we explore other than biomechanics related to orthopedics. We also explore other biomechanics related to cardiovascular and dentistry. So if you look, the complete value chain is there, starting from design and then mechanics, materials, all the way to production. And that picture over there is one successful story from a company called Nitium Tech Sendirian Berhad. So Nitium Tech Sendirian Berhad is a company that produce dental implants and dental implants. Equipments that we use as far as materials are concerned, we use materials characterization, mechanical testing equipments like Instron, and medical imaging like CT scans, X-rays, CBCT for dentistry, MRI. And for mechanical analysis, we run finite element analysis using various software. Some of us use MSc.Mark, some others use Abacus or ANSYS, but those are finite element software. And then we also have design software like SolidWorks, and other software for anatomical reconstruction, three-dimensional reconstruction of anatomical parts. We use Materialize. And some facts and figures regarding our successful research ventures in the group, in the center. We have received about 20 million in terms of research grants, more than 300 publications in ISI, 31 patents granted, 46 PhD graduated, and 38 masters graduated. Right, as I mentioned to you, now I will show you an overview of the kind of projects that have been completed or still ongoing. Yeah, so we start with this very complex analysis related to the spine. So this is a very interesting study made by Mina Alizadeh. Now, this study, we can actually create a simulation for spinal construct, which is otherwise will be impossible for surgeons to actually analyze, because surgeons don't have the freedom to play around with patients. But as far as computer simulations are concerned, we can actually do anything we like in a simulation. So what we did was we analyzed 8 different combinations, 8 different constructs for burst fracture. So I think this is the thoracolumbar junction, L1, burst fracture of lumbar 1. And then we attach the rods, pedicle screws and rods. And then we analyze what happened to the IVD, to the intervertebral disc. And of course, we can vary what would be the most rigid construct or the most efficient way of applying this construct to a burst fracture scenario. This is a rather simple study, high tibial osteotomy. We analyzed 2 different implants, one Pudu and one Tomofix, and analyzed the stability between these 2 fixation plates. This one is external fixators for distal tibia, and we can see that is comminuted fracture at the distal tibia, stabilized using external fixators. We compared 3 different fixators, the delta, the Mikovic, and the unilateral fixators. And then, of course, using finite element analysis, you can see which plate give you maximum stability. And that is another complex geometry there with 6 bone fragments of the distal tibia. Another study on the spine, this one is cervical corpectomy. Once corpectomy is done, you need to stabilize the section using plates, and we can compare this. In this study, we compare between a double plating and a single plating. So that blue implant is the double plate, and the yellow implant is a single plate, and we can analyze the stability, whether it is sufficient to have a single plate in order to have a very rigid construct. Next is glenoid. Glenoid is a very difficult place to put implant because of the thin bone section of the scapula. So there is no much bone stock that we can play around with. And in this particular analysis, we analyze the glenoid implant to reduce or to minimize or maybe to eliminate the rocking horse phenomena, a very common phenomena after glenoid implant replacement that can loosen the glenoid implant component. And you can see that we can vary different pegs, different number of pegs, and then different depth. And then, of course, we can also vary whether you want to use cement, bone cement, or not. And again, you can analyze using finite element analysis and look at the amount of stresses generated at certain region, as well as the total displacement after you apply load. And there is various different loading conditions that we can simulate in order to reduce or to minimize the rocking horse phenomena. Knee kinematics. This one we analyze using MSc Adams, the kinematics of the knee for total knee replacement. That is the femoral component of total knee replacement, and then we can analyze the kinematics of it. Because the knee joint is not actually a simple hinge joint. It is a bit more complex than a simple hinge. So in order to incorporate all the movements of the knee joint, we can run the kinematics of the knee. This one is projects related to dentistry. So in this particular study, we compare 2 different approaches. One is the intrasinus and the other is extramaxillary. And then we can produce results showing high stress regions or not between the 2 approaches using various different types of implants. So this is another complex geometry to play around with because of the thin bone section in the craniofacial area. Dental post. Dental post, it's a very tiny bit of implant inside your tooth. So you can, if you make a cross section, that's what you can see. The post, and sometimes they use cement, sometimes not. And we are trying to develop an functionally graded biomaterial, FGBM, functionally graded biomaterial, because that post, even though it is just a simple cylinder, the variation of stress for the top and the bottom part should be different. in order to match the surrounding of that post. So that is the challenge. If you use a standard post with a single material properties, then it may lead to a bone resorption. So we are trying to develop a functionally graded biomaterial based on the surrounding tissues. This is dentin bonding. Again, we vary the primer 0% HEMA, 5%, 25 to 50%, and we compare with the control model. That is the restored premolar tooth, and the section replaced with composite resin. And this one is cardiovascular. We're talking about any data sets. In order to look at these data sets, is it possible to make an auto segmentation? So this is a computing related topic for the intravascular auto segmentation. This is cancellous bone. This is the work of Ardi. The work of Ardi, our current director of MEDiTEC, and this is an interesting study where we compare the actual cancellous bone with the one that we developed using micro CT. So you can see model 1 and model 2 there, and then we analyze the three-dimensional construct of the cancellous bone that we obtained from micro CT. And the line of fracture is close to perfect. Yeah. And then we compare with that with the experiment. We compress the cancellous bone, and then we see the fracture line there. So you can see a direct resemblance between the computational simulation, computational prediction, and the experimental results. RD also work on permeability studies, basically because cancellous bones, you have gaps. It is not a solid structure like the cortical bone. Cancellous bone, you have gaps where blood can pass through. So this study looks at the permeability of cancellous bone, and you can see comparison between this study and others that have done more or less similar kind of work. And we also showed the velocity, the pressure, and flow trajectories in our studies. We also vary the degree. Instead of just taking the sample in vertical sample, we also vary the sample at 45 degrees and horizontal and look at the permeability of the structure. Right, so let's move on to the materials, which I have about 5 or 6 minutes. Biomedical materials, so this is the work that I carried out for my PhD back in the year 2003, 2002, 2003, completed in 2005. So I work on cementless hip stem. So other than the biomechanical study, biomechanical analysis, we also look at biomaterials. And of course, biomaterials can be in a form of metals or ceramics or polymers. And in this particular example, you can have a metallic stem for hip stem, metallic stem. And then for the tribology section, we have the acetabular cup made out of ceramics. So it is metal on ceramic hip stem, metal on ceramic hip stem. And then you have that polymer insert. So all those three materials have to be biocompatible. Well, it can be bio-inert, and the kind of research that we do is to incorporate all these non-living materials, metals, ceramics, and polymers into living tissues. So that's the challenge. And the kind of research that you can do related to biomedical materials is huge, is a lot. And I will just show some of the work that that has been carried out in this biomedical materials field. And of course, this is a standard slide that we teach our materials science students. This one I took directly from Calista book, Material Science. And this is my favorite slide when I teach my student structure, properties, and processing, where properties depend on structure and processing can change the structure. So even though you have one material, if you add another material, turning it into alloys, and with different types of heating rate, cooling rate, the hardness will be different, the microstructure will be different, so the properties will end up being different. This is a continuation of RD's work. So RD completed a work on cancellous bone extensively. So he has the computational work on cancellous bone, solid mechanics work on cancellous bone, fluid mechanics work on cancellous bone, as well experiments. So this is the result. These are the results from his students' work related to cancellous bone, looking at the mechanical behavior of cancellous bone. And you can see that you can see the fractured line, you can see the fractured surface, and this in particular is dry. And of course, the real bone, which is inside a simulation, inside a simulated body fluid, will be different from the fractured surface when it is dry. We have degradable bone screws. This one is iron. Again, our attempt at functionally graded biomaterial, partly because the bone, if you cut the bone into sections, you can see various material properties, mechanical properties of each section is different. So if you want to put an implant into bone in particular, it has to be functionally graded. Maybe the outer layer has larger stiffness than the middle and the bottom layer. So we try to develop this, and iron, a degradable one, has an added advantage in a sense that there is no need for you to have a second surgery to remove the implant. So the implant will basically absorb, will basically degrade over time. The challenge is to make sure that these implants will not degrade, will not absorb before new bone formation. So the challenge is to make sure that once you insert these biodegradable screws, the healing will take place, and only once the bone is fully healed, the degradation starts. So that is actually the challenge. And again, this is work by RD on porous magnesium. So we simulate the corrosion, degradation of magnesium after 24 hours, after 48 and 72 hours. Then that degradation is crucial. Again, if you were to use this magnesium implant as a scaffolding, then it needs to, first of all, it needs to degrade, which magnesium is good for. But we must ensure that it only start to degrade after bone formation, after the formation of bone, so that the fracture can heal before degradation starts. Again, I have a lot of slides related to the work of RD here, and this is another bone permeability studies. We try to compare the actual cancellous bone, the picture number 8, compared to other idealized structures. So RD created this 7 idealized structure, and see which idealized structure can mimic the real cancellous bone. And then we look at the permeability and, of course, other solid mechanics analysis. Okay, time is up, 11:25. I still have a lot more slides that I need to show, but I think it's good for me to stop here so that there will be some a time allocated for Q&A, and let me go straight to the very last or second last of my slide. Hang on, let me click escape, and I need to give acknowledgements to all these names because all the stuff that I presented to you are all the work of this of them. Yeah. And so I just supervise their work. The hard work actually comes directly from them. So I need to acknowledge these individuals, these great individuals for their work. And of course, these are all PhD students. And these are all my master students. Yeah. So thank you, everybody. And thank you for listening. Okay, Arfan, I guess that's all.
Thank you. Thanks, Prof, for nice sharing. And
Now I can see my
congratulations for winning the huge research grant in your research lab. And so now there is a Q&A session. So if you have any kind of questions regarding the professor, you may ask directly or you can type in inbox. So Prof, there is a question from Kiara Sabri, and she's asking, can you discuss the complexities of regulatory approval and clinical trials for novel implementable devices and how these challenges are being navigated in an era of rapid technological advancement?
Right. If I
This
get
is
the
written in
question.
chat box, so if you can access, you can read it directly. Otherwise, I will
Okay, let
repeat
me check.
it again for
In
you.
chat, yeah.
So the question is, can you discuss the complexities of
Okay.
regulatory approval and clinical trials for novel implementable devices? And the second part of the
Thank you
question
for
is,
the question.
and how these challenges are being navigated in an era of rapid technological advancement.
Right, thank you, Faira, right? Faira, thank you, Faira Sabri, for your question. Yeah, for clinical trials, regulatory approval is under MDA, which I and RD and I happen to be one of the committees in the MDA. It is not straightforward. It has to go through a CAP, and CAP has to check and test your product, and you're talking about clinical trials here, right? So if it is, for example, if you have an implant that you want to get regulatory approval, then it has to go through all these clinical trials, and then it has to be registered with MDA, and unfortunately, it is not as easy as it sounds. You have to go through a CAB, and that CAB will have to check to ensure that the implants that you develop follow all the steps required for approval. And then you say clinical trial for novel implantable devices. Yeah, and now these challenges are being navigated in a rapid technological advancement. I don't know, because these days when we talk about rapid, we always talk about rapid prototyping. Yeah. So other than that, I'm not sure. But I guess the reason why it is called rapid prototyping, if that is what you're trying to ask, then yes, we have SLS these days, technology that can be used in order to create an implant for testing, for rapid testing. Yeah. So that's a very brief answer to the question. Thank you, Faira. Where are you from, Faira?
I'm from UTM.
I thought you're from a company or something. All right, okay. You're doing your PhD, I guess, yeah? All right. Okay. All right, Arfan, thank you so much. I think I don't want to take the
Sorry,
time
bro.
of
I
our
think
next presenter.
voice, your mic is, I think now. Okay. Thank you, bro. So Dr. Farah is also from UTM.
Oh, okay.
Okay. So is there any other question? Okay. So if there is no question, then we are moving to the next presenter. So thanks for your time, and once again thank you. So without further ado, now we have another presenter online. So the next presenter, let's welcome to the next presenter. The next presenter is PN City Nuraskin with Mohammed Jazuli and Cheese Brown in the Brain Occupational Therapy Center, Malaysia. The title of presentation is The Importance of Children Development. How can technologies help the growth? Changing the mindset of negative influence to positive feedback. Positive feedback. Okay, over to you, City Nuraskin.
Okay, thank you, Mr. Arfan, for the introduction. I share my slide now. All right. You can see my slides now, right?
Yes,
All right, thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and very good morning to everybody, to everyone here. So first of all, I would like to thank you to the organizer, especially Dr. Hasrul, for this invitation, for me to share some information regarding children development, basically, because I hope this sharing presentation can help further in rehabilitation of children with special need. Me, my team, and I at IndieBrain hope that the AI, all people, all professional in this technology industry can create something that what we call functioning and generalized in the same time, enhance the children's developmental milestone. So once again, my name, I'm Siti Norashikin binti Muhammad Jazuli. Most in my field, they know me as OT Shikin Jazuli, an occupational therapist from Indie Brain Therapy Center. Basically, Indie Brain, we give rehabilitation services for children below 12 years old. We are a pediatric center. So this is once again the topic that we will discuss or we will share today, the importance of children development, how can technologies help the growth, and changing the mindset of negative influence to positive feedback. This is because nowadays we talk about or we see about negative influence or negative influence to children's development by using all the new technologies. Okay, the presentation will cover basically the children development, effect the technologies, some update that we did at IndieBrain, and how to change the negativity to a positivity. When we talk about children's here, every children is a star. They are unique in their different way. They are very individualized and strength. Their strengths are very individualized. They have their own strength, like Howard Intelligent mentioned. There's 9 intelligence of children. They sometimes are very verbalized. Some of them are very active, which is bodily kinesthetic. Some of them uh, more into it themselves, which is intrapersonal, but some of them are very socialized well with other peoples at schools, at new playground, because they are very interpersonal. So every children's are different, same as for children with special needs. When we know and observe as an occupational therapist, as a parents, as a teachers, if we can identify further what is their intelligence, they can help us further to plan the rehabilitation plan, so that we can give them to be the maximal functioning or performance of themselves. So that's the important things, to identify their intelligence and interest. So this is children's developmental needs. Our children's need very good health in order to develop well, proper education, emotional development, identity, which is more related to the intelligence, self-care skills, social presentation, and family relationships. These 7 items is very important in order to help our children to develop functionally and maximally in their performance. However, in this sharing, I want to focus more on social presentation and family relationship. For family relationship, uh, post a pandemic, we can say that we during the pandemics, everybody are using all the technologies in order to engage, in order to do our roles as a teachers, as a student. So we do use a lot of technologies during the pandemic. So what we can say, during the pandemic, all the technologies, or we call role, make our occupational balance quite disturbed. We all under one roof. We do our work at our house, our house. We do parenting in our house. Our children go to schools in the house. So that's put a lot of pressure, especially for parents. And sometimes we neglected by using the technology, using the technology without a proper purpose or guidance from the adults. Other than that, for social presentation, what we can say, nowadays, if we look at our environment, all the children as small as 1 years old, 2 years old, they have their own gadget. We can see in a restaurant during the dining or during the dinner time or lunch time, when we have our dinner, we can see children is occupied with their phone during that period. So it it helped, it actually it gave some a social presentation to the child in order for other people to engage with them. And we also can see when they are in a group, they are all into it, to the technology, to the gadget that they use, without proper much of engagement or communication happens during their social activities. This is children's development building blocks. For us in rehabilitation, the children developments are building blocks, which is we need to strengthen the below building first in order to achieve the functioning buildings of academic and functional performance. So basically, the two red color and yellow, a bit orange color, sensory processing and intense sensory processings are developed during in the womb, and then it's continue after the delivery and throughout the life. Usually the palmar, all the reflexes will fully integrate by age of 3.5 years, while the sensory system will continue develop throughout the lifespan. So in order to get the good academic and functional performance, we need to stimulate their basis development well. So for the children developments, the factors that influence these are the four, which is biological, contextual risk, psychological risk, and also environmental exposure. I want to focus more on the three areas of environmental exposure, which is more towards the factors influence electromagnetic and pesticide exposure, while the psychosocial risk is more towards cognitive stimulation and caregiver sensitivity and responsibility, while the contextual risk is more toward exposure to violence or maternal depressions is under the contextual risk. What I want to focus more on the psychosocial risk, which is the cognitive stimulation. When we give our children the technology or the gadget, more or less the gadget, what is the input they get from the technology, from the gadget, is important in order to influence their development, and also the responsibility of us parents in order to engage with what our children see or watching is important in order to influence their developments. These three external factors are much important compared than the biological factors. So about the studies, effect on technologies on children's development, we can see one, that's from Dua Al-Mulghel et al. 2021, technology use is associated with a negative impact on children's sleep and behavior. We did some research, some studies with our children and also at schools, children that use technology gadget mainly without proper guidance from the parents, and they have late sleep that affect their behavior, sometimes become more aggressive compared than others. Number two, watching an excessive amount of television and videos by children had significant influence language developments and children behavior disturbance. These two are very linked, where when children unable to develop their language properly, they will have issue on expressing their emotion. So usually children with language development issue, they will use behavior more or less, they are using the temperament in order to express their feelings. Number three, the increased use of smartphone had been reported to be associated with passive-aggressive social incompatibility, obsession, addiction, and anxiety, where we can see there's a rise number of anxiety cases in children as small as at primary. We met with children at age of 10 years old that school refusal because of the anxiety attack that they had during in the schools. Number four, spend too much on the computer negatively affect the children in area of low concentration, lack of attention, and disorganization, undeveloped language skill, creativity, and imagination, which is more toward the ideation. We did some studies for 201 students, year one. We will show you later. And yes, it affect much on their attention, disorganization, especially in their handwriting development or handwriting skills. Number five, from Raymond Fitchett et al. 2020, some computerized cognitive training program have been shown improvement. There's improvement, but sometimes there's no significant effect on it. The improvement of child attention is depends how it been used and learning approach being applied, and usage of no educational purposes toward the computer more than 2 hours can affect on give some feedback of attention deficit and hyperactivity problems, and it reduce the child's attention to the task. However, SARS, socially assistive robotic, that the study been done with autism spectrum disorder children, is improve the social skills children. This is some updates for IntiBrain pre and post pandemic. When we see the ratio of the patient, we can see the new cases age range are very different compared than pre-pandemic, where during the pre-pandemic, most of the students that be referred to us are those at a age of 6 to 9 or to 10, which is more towards students that went to schools already. However, post-pandemic, we see children as early as 1 year to 1 year plus, and our ratio now is more toward the range of 1 to 3 years old of age. While the number of children, we see children now after 1 year of pandemic, the cases are about 70 to 80 cases per month, which is they come to Indie Brain as appointment basis, and the new cases also increased to 20 to 30 patient per month. And we know that from the new research mentioned, the ratio of autistic is 1 to 36. This is 7 years old children's performance that we did study for 201 students. We focus on the handwriting speed, the blue color, oculomotor T1, the orange color, which is we focus on oculomotor pursuit, stabilization and localization, and also T2 for visual search. We give them a picture and they need to point a small pictures, small items in that big pictures. From this short study, that we identify that 66 students from the total did not meet the criteria of normal handwriting speed. For the 7 years old children, their handwriting speed need to be between 17 to 35 letter per minute. So there's 66 students, children that are able to achieve that normal range of handwriting speed, while 36 students having issues with their oculomotor, which is their focus, their tracking, their stabilization and localization, and 28 students unable to find the correct item in the big pictures during the visual search test. And generally, from all the tests been done, 13 children noted need further OT in-depth assessment. So this 13, based on this study, we can relate with the new with the recent studies mentioned that there might be 1 to 2 students special needs in one class, which is in the mainstream. So it's correlate with the data there. So in the summary, negativity towards the positivity, in the using the model assistive technology HAT model by O'Brien and Kohanek 2020 in the book of occupational therapy for children and adolescents, we need to focus on these three aspects during in terms of the technology, which is number one is the human, the child personal factors. We need to identify the human, along with the activities that the child want to engage. So they have the inner drive to participate using that technology. They have the adaptive response towards the activities using the technologies, and the technologies allowed to be generalized, meaning it need to be successfully participate by the children in the activity at natural environment. Either it can be used in the house, either it can be used at the schools, or during at the playground where they used normally go. And actually, at IndyBrain, we also collaborate with organization and person who did their research study in terms of AI that can be used in rehabilitation. So it's two aspects that we can aim in the technology, which is what we call as an and or as an mean. SNN is activity that we use is to focus on the activity of the child, occupation of the child. For example, the AI used to help in terms of handwriting skills, to help in terms of potty training, in AI that can help in terms of reading or using clothes. That one is more SNN AI aims. However, most of the AI that we see focuses on as as a mean, which is a component of a child. Sometimes the AI that been produced are focuses on hand grips, on motor planning, or improve the awareness of left and right. So that one is AI that focuses as a mean. So technologies and children developments, there's pro and cons. I didn't say that we cannot use the technologies at all. No, it's good and it's bad. It depends on the needs of the child, and either it's the needs or it's wants. Either we apply the technologies for the child needs, or because of the child wants it, or we parents want it because we want to do our work, so we give the technology to the child so that they can occupy themselves, and we can do our own work at that particular time. So the parenting aspect is important also by using the technology, because when we look at the parenting style, there's one things that we call a neglective parenting style. Sometimes we give them the technologies in order for us to have our own time. Technology and the children's, it good if all the AI and technology can be used as same as to enhance the children's building blocks, and if the technologies can involve the active movement of the child. Because if you look at the brain plasticity, if you look at the children's sensory development, they need active movement in order to develop more, in order to enhance more their cognitive ability, and hope that the technologies can involve of more engagement. So basically, engagement at the end of the day, the most overwhelming key of success is when the child able to engage and develop the positive functional involvement. So I think that's all for me. I hope that can give some ideas or benefits others, especially for those with special needs. Keep in touch with us at Indie Brain, and also can follow us with our community project. Indie Brain is not only a centers. Me myself also participate in community, which is in for NGOs like Persatuan Kanak-Kanak Autistik Islam Johor Bahru, Yayasan Zuriat Care, and Awas Badi, which is more focuses on parents with special needs, mainly autistic, and also working with build awareness of mental health and suicidal thought. Thank you. That's all for me. Thank you.
Thank you. Thanks once again, Doctor, for interesting sharing. There are two questions regarding your topic. I'm reading for you. The one question is from Devi. She is asking, my son is 8 years old and diagnosed with severe dyslexia. I am still waiting for the treatments since the trophy unit in my country is very limited and require a long reservation period. Do
Sorry.
you have any recommendations for home therapy by parents? Thank you.
Eh, All right, I stop. Sorry, once again, which one?
Can you unmute?
Sorry?
May I repeat the question?
Yes, from
Okay.
which one? Which
It
one?
is already in books and you can read, but I'm repeating once again for you. So question is, my son is 8 years old and diagnosed with severe dyslexia. I am still waiting for the treatment. Since the trophy unit in my country is very limited and requires a long reservation period, do you have any recommendations for home therapy by parents? Means she's asking by home therapy for the treatment of dyslexia.
Okay, thank you for the question, Miss Devi, Mrs. Devi. Actually, like I mentioned earlier in the slides, children developments are building blocks. We need to focus on the basis of development so that we can achieve the higher function of the occupation of the child. Like what Miss Devi mentioned here, if we looking at the dyslexic, we are looking at the occupational of the child. The problems are they can't read, they can't write, all that issue. However, the underlying of the problems dyslexic is more toward the sensory or proprioception, is more on towards the visual praxis of the child, and sometimes because of the visual fields are very different from other normal children. What we can suggest, one thing is do a lot of physical activities at home that involve bilateral coordination so that the brain can work as integrated as whole. So we strengthen the brain first. We can do a lot of cross scrolling, any activities that has cross scroll effect to the child, so it can influence more on the brain, enhance more on the brain. Other than that, we can use a lot of tactile, which is the hands, in order for them to learn about all the alphabets. For example, if they want to know about, let's say they write the B, we can give them hold the B first, and then write in the medium of sensory like paper or sand or rice or any type of a texture, in order the brain to understand, oh, this is the way B is. Then later on, we will go to paper pencils by by give them to write it properly in the pencil. So you can do a lot of physical activity first before go towards paper pencils activity. Hope it helped you.
Thank you, Doctor. Yes, physical activities is very key in order to means away from technology in each and everything. So there is another question from Dr. Faira Sabri. She is asking, there is a claim that grounding or earthing can help with child's frontum due to the gadget or exposure. What is your opinion on this? How effective is this technique?
Okay, grounding and earthing. Yes, I know about this one. Actually, when the main important thing while children have tantrum in our first line during the using of gadget is because of the behavior. What we can use at the first place are the behavior approach to the child. Grounding, let's say we are do rhythmic movement activities, we cuddle him or let the child go down and give some pressure at the body, is very good and effective way in order to make them calm. I have one patient that have this kind of problems. They have tantrum during the session because they want their phone. During the activity, they want their phone. He want his phone. So what we did is we just pull off the phones and give to the mother, and then on that particular part, I need to rock the child, and in the same time give auditory stimulation with very calm voice in order for them to be to less tantrum on that particular time. So rhythmic movement is very good in order to give more calmer effect to the child.
Yes, thank you. She is further asking, is it true that if the parents has high intelligence level, they will have a high risk of having aesthes- aesthetic child?
Autistic
Sorry
child.
for pronunciation.
Okay, Dr. Fira, I think Dr. Fira Sabri, right? Okay, actually, new recent study regarding the causes of autistic is two. It's divided into two, which is the number one is genetic, and number two is de novo genetic. What is the meaning of de novo genetic? It happens during the pregnancy. It's not because of the hereditary or the family background. So I think we saw some of the childrens with parents with high intelligence level that having autistic child. Sometimes it's because due to lack of engagement or communication. Sometimes the intra-person characteristic of the parents, um, we hardly to engage much with the child. I didn't mention about highly intelligent level of the parents, because sometimes when we do assessment, when we do assessment to the child, we also assess the parents. We also observe the parents. The child with autistic, sometimes they have parents that lack of communication. So I think it's more not only the high intelligence, the parents personality itself can influence the child. It's more on environmental effect on the children.
Yes, you are right.
Arfan,
There
Arfan,
is another
maybe I can.
question
Yeah.
from Dr. Sabri. So she is asking directly. Yes, Doctor, you can unmute yourself and you can ask.
Point City,
Yes.
I'm Dr. Fira. Because this topic is very interesting to all the staff. I have one more question on behalf of one of our staff. The staff asking, there is claim that if the children is having tantrums, we just have to let them having the moment, don't disturb them. So for your, because the answer for previous question, you said that the interpersonal interaction between the parents and the children is very important. So how is your take on this issue? If do we have to let the children with the tantrum, or we have to hug or give any touch to them?
Okay. Thank you for the question, Dr. Fira. During at the center, or me myself with my children, usually we do 3 times trial first to consult with the child in order to manage their anger or to manage their tantrum. For example, if the child's having tantrum that side, we consult him or her first. I know you are angry. I know you want your handphone, but this is enough for you. You already, let's say, 1 hour with the gadget. So I hope you can calm yourself one time. Still, second time we try again. I know you are angry, but this is not the way for you to communicate with me, or you can communicate verbally with me. We can say anything positive to her, to him or to her, in order to calm them down. 3 times again. I know you are angry, but still I can't give you the handphone because it's time and it's over the limit now. You have your own you have your own phone. It's about 1 hour 1 hour ago, so it's enough for you for today. So after the 3 times, I'll do the ignorance. Ignorance can go as far as the child did not disturb or hurt other people's. Ignorance can come as long as the child did not hurt himself or herself, and ignorance can come as long as the child did not disturb the environment. If the child is just tantrum that side, let it be. Let it be after you consult them 3 times. And then if the 3 items come in, then we need to go towards another more in depth with the child. Maybe we can need to hug the child. Maybe we need to just cuddle him without any verbal stimulation or verbal explanation to the child anymore. So 3 times and then ignore, as long as no other harmful happened. Usually when they calm down, let's say they calm down about 1 minute or few seconds, when they calm down, we engage back with them. See, you can calm down. Now, can I know what you want now? And then screaming come again. We just ignore back. And then come. They calm down again. Then we go inside back. Yes, now you calm down. This is you. I love this kind of you. Calm down. Talk to me nicely. So we only focus on positive things that they or he or she do at that particular time in order to enhance further the positive behavior on the child. I hope it's helped.
Yes, yes, thanks, doctor. So I think there should be
Thank you.
balance between physical activities and applications or gadgets or technologies. So thanks for interesting sharing once again. So
Thank
I
you.
think if there is no question, so there is end of this session. And for the next session, I would like to invite our next chairperson, Dr. Noor Saira Binti Mustafa. So over to you, Noor Saira Binti Mustafa.
Hi everyone. Thank you, Arfan, for such a interesting session just now. Okay, hi everyone. Welcome to our symposium and thank you for joining us today. I am Nur Shahira binti Mustafa and I will be your chairperson for this session. So without further ado, I would like to invite Dr. Swee Leong from the National University of Singapore to share about his topic. Please welcome to the floor, Dr. Swee Leong.
Hi. Hi, thanks for having me today. Please allow me to share my slides.
I'm sorry, but I cannot hear you clearly, Doctor.
Hi, sorry, can you hear me now? Hi, hello.
Hello? Yeah, it's better.
Yeah, so once again, thank you for having me today at this symposium. Are you all
Sorry,
able-
Doctor.
are you all
On
able-
the control room, we cannot hear you clearly.
Hi, sorry. Yeah, let me bring the mic closer. Yeah. Are you all able to hear me now? Hello. Hi. Hi, hello. Are you all able to hear me now?
It is still a bit slower, but we can already see your slide.
Are you all able to see the slides?
I'm sorry, Doctor.
Hi, are you all able to see
That
the slides?
I mean, like we can hear your voice, but it's a little bit slower.
Okay, sorry, please. Give me a moment. Yeah, are you all able to hear me better now?
Sorry?
Are you all able to hear me better now?
I can hear you, but then it's still a little bit slower than, I mean, like if you can increase your voice.
Oh, okay, I will try to speak louder. I think that's the best I can do now. Yeah, so,
Okay.
are you all able to see the slides?
Yeah, we can see your slide.
Yeah, let me go to full screen then.
Yeah, and it's now in full screen.
Okay,
Yeah.
thank you again very much for having me here today. Yeah, so today I'll be talking about 3D printing in healthcare and about the current and the future progress or perspective in this technology, especially focused on healthcare technology. So a brief introduction for myself. Yeah, so currently I'm working as an assistant professor at the National University of Singapore, but I have around more than 10 years of experience researching on 3D printing or what people call additive manufacturing. So within NUS, our research for additive manufacturing or 3D printing are consolidated in this NUS Center for Additive Manufacturing or AM.NUS in short. So for this research center, it's a multidisciplinary center. We draw on expertise from the College of Design and Engineering, Faculty of Dentistry, Faculty of Science, as well as our medical school. Yeah, so we have a wide range of commercial 3D printers available for our research. mainly on polymers, metals, as well as biomaterial, or what we use for 3D bioprinting. Yeah, so in the next few slides, I'll briefly touch on each of these applications for medical healthcare. Yeah, so without further ado, let me give a brief introduction on 3D printing. So for those unfamiliar with 3D printing, basically we are using digital files. They are designed using commercial software like your SolidWorks or your Fusion 360. And these files are then sliced and then input into our 3D printers for fabrication. So according to the ISO standards, now the technology have advanced and expanded into 7 main categories: the material jetting, binder jetting, powder bed fusion, bed polymerization, material extrusion, directed energy deposition, as well as sheet laminations. So within these 7 main categories, each of the commercial printers or manufacturer has come up with their own technology or terminologies for their process, but they can fall mainly into these 7 categories. But as mentioned, let's give a brief overview of the 3D printing process. First, we must have the design files that are drawn, or you can use scanners, especially for healthcare. People use MRI or CT scan images to recreate into 3D shapes. So these 3D shapes are then converted into 3D printable file, mostly STL file currently used most widely in the commercial market. And then the STL files are then sliced and then fabricated layer by layer using the 3D printer. And then finally, you have the end parts that can require or may not require post-processing before the end-use application. So what can be 3D printed? I have mainly shows our 3D printing capabilities in NUS that cover metals and polymers. So these are what I call the established materials that have been used in 3D printing, but research are still ongoing. So there are people printing glass, ceramics, food printing, or even composite material, or even living cells in the form of 3D bioprinting. So if we look at the development of healthcare using 3D printing, in the past, because of the technology or the technique restrictions, most of the parts are fabricated using polymers or plastics. In that sense, these are not functional parts that we can use on the patient itself, but they are very useful in terms of surgical aids or even in terms of models for the medical students or even the surgeons to plan their surgery, to visualize their cutting path, for example, or how the surgery should be done before going into the operating theaters. We also use such models for education purposes currently because we have short of cadavers for the students or the medical students to practice on themselves. So presence, because of the growth of the evolution and the advancement in the techniques, people start using 3D printing to print functional parts that can be used in healthcare, such as your load-bearing implants, like your hip implants, spinal implants, or your dental framework, dental applications, braces, or even dental implants. So one of the most popular application for 3D printing in healthcare is actually tissue engineering scaffolds, because we are able to design complex shapes. We're able to design very unique properties used during 3D printing. I think 3D printing application in healthcare is sort of amplified, especially during the COVID pandemic. And we can see that during COVID pandemic, where the logistic, where the process chain or even the production line are heavily disrupted, hospitals or even end users start using 3D printing to solve some shortage in terms of the supply of medical devices. For example, we have people printing personal protective equipment during the pandemic, like your face shield, your respirator, or even filters for your respirators itself. And during the pandemic, we need to train people in terms of doing the ART or doing the swapping test. Then people print training or visualization aids in order to carry out such training without risking the medical personnel close contact with the patients before they are ready to go into the field. And of course, in terms of medical devices, we have people printing ventilator valves, mask connector, or even emergency respiration devices. One of the most commonly used applications that people have done is actually printing the swab. There are shortage, heavily shortage, especially in Singapore. So at US itself, we were tasked to print using the 3D printers on the nasal swab for the testing during the peak of the pandemic. So in the future, what I'm looking at in terms of 3D printing for healthcare, of course, by improvement in terms of the accuracy of the biomodels, not just in terms of colors, in terms of the visual outlook, but also in terms of the texture, because we are using it for training purposes or for planning. If we have good or same texture between the 3D printed model to the actual cadaver or actual patient, the doctors will be able to use such model for practice. And a key advantage of 3D printed model is that each and every one of the doctors or the student can have one copy or one model that they can bring home for practicing at their own time, at their own comfort of their room, of their home, as compared to cadavers that we need to have special storage or special room to keep them in place. Of course, as mentioned, I will continue to see the growth of 3D bioprinting in terms of printing cells for organs. Now we are not at the stage of implantation or the printing of the whole organ. So 3D bioprinting product has mainly been used for the printing of testing for, let's say, new cosmetic testing or new drugs testing to test for allergies, for example. So in the future, we hope to see 3D bioprinting printing a real implantable organs that can be implants into the patients, because we do know that transplanting of implants, the patients needs to be on the wait list, on a long queue, and to find suitable implants or organs for the surgery is a very demanding and very rare occurrence currently. In the future, I also look at 3D printing of food, where we can alter the texture or customize the nutritional values for the patients. And of course, 3D printing of drugs, which are currently already available in the market, but I see new designs in terms of material, in terms of control release. For example, some elderlies can have multiple chronic diseases, and then throughout the days, they will need to take drugs at different timing. For example, if 3D printing advanced, we can even have one drugs that cater to specific patients, customize the release of each of the drugs that target each of the illness that the patient have. So they will only need to remember to take that particular tablets, for example, in the morning, and then before moving on to the next day, for example. So there's no multiple recurring taking of drugs that they need to remember, like for 3 p.m. or 2 a.m. or even 10 a.m. I need to take certain drugs. And of course, 3D printing has also been used for wearable devices. For example, flexible electronics. This is interesting because we do not need conformity, let's say for measuring of blood sugar level, for measuring of blood pressure. Currently, the devices are very bulky, and the patients are reluctant to carry monitoring system 24/7. And that actually restricts their mobility. For example, we have patients, pregnant ladies, that need to monitor the baby heart rate or the fetal heart rate 24/7 a day. So now currently they have wear these belt-like devices. They are very bulky. They cannot carry on with their daily activity. But with 3D printing, we are actually able to reduce the size of such devices to improve the comfort of the patients, as well as to improve the mobility so that they can still carry on with their daily activity as per normal. So currently in my lab or in my research group, what I focus on for biomedical applications is very much heavily focused on metal 3D printing. I also do a bit of polymers as well as a bit of 3D bio printing. So for metal itself, I'm looking into new design where I can design complex shape, customized implants that are previously not available or not possible. I also look at new material. How can I use the new material to provide better properties for the patients or better clinical outcome for the patients? In terms of polymers, I have focused quite heavily on tissue engineering, scaffolds that helps for wound repair, wound healing, for example. And I also do a bit of bioprinting where I do tissue models for testing in terms of skin tissue.
Excuse me, Dr. Sri Liang, there's a part of your slide, the upper part, is been, I mean, like it's partially closed.
Okay.
Oh yeah, that one. Yeah, all right. Okay, that's good. Okay, thank you, doctor. Sorry.
No problem. Yeah, so as I was saying, 3D bioprinting, currently we are focusing on printing tissue models for testing. For example, we print skin tissues for cosmetic testing, for toxicity measurements in terms of new product. We also printed lung tissues, especially during the COVID pandemic, for testing out new drugs, for testing out new allergies, or even the effect of the virus on the lungs tissue itself. Yeah, so as I mentioned, I focus mainly on metal 3D printing. And so in the future, what I'm looking at is actually how can we design these new implants such that it conforms better to the patient, or how can I mimic the actual structure of the bone, for example. Currently, we are using very traditional CAD modeling or computer-aided design modeling to draw out such implants. But is there a way that the computer can generate its own design, or what I call generative design, based on the inputs of the patient's requirement? For example, the size, the modulus, the stiffness, the strength that is required for the implants. And then the computer can generate out such design itself. So in this way, I'm using machine learning, right, to keynote or take note of the input parameters in order to create the final output in terms of the shapes, the design, and of course the property of the implant itself. So with that is what I want to share today. And feel free to link me up using the QR code, or you can drop me an email if you are interested to discuss further on such topic. Yeah, so I open the floor for discussion. Thank you.
Yeah, okay, doctor. There is a question in the chat box from Dr. Fira. She asked that among the various biomaterial classes, which material is considered as one of the biomaterials that face significant challenges when it comes to 3D printing, and why?
Yes. Yeah. So for biomaterial, right, I classify them as biocompatible material such that they do not provide adverse effects when they are implanted or in touch with the patients. So in terms of polymers, we have the PCl, PLA, metals mainly focusing on titanium alloys, and of course bioprinting, we are using hydrogel like your gelatin, your cellulose. So each of these class of material has their own challenges. But I think the main challenge or the most challenging material that we are working with is actually hydrogel with living cells inside for bioprinting. Because other than ensuring that the hydrogel can be printed, they can maintain the structure after printing. The viscosity needs to be low, but it cannot be too low that it cannot be printed through the 3D printer. So how we balance this viscosity or this flowability problem such that I can print the material while still maintaining the structure of the material itself is a challenge for 3D bioprinting. Then now we are adding into living cells, cells into the hydrogel. So these living cells, when undergoing the 3D printing, they undergo mechanical stress as well. So we do have to ensure that the stresses endured by these living cells do not kill them during the 3D printing process. So we do still want living cells that are printed, that can be livable, can be cultured after the bioprinting. So there are mechanical aspects, mechanical challenges to 3D bioprinting. There are also the biological challenge to 3D bioprinting, which I find is the most challenging currently.
Thank you, Doctor, for great sharing. I guess that's it. There's no more question. Thank you, Dr. Swee Leong, for such a great sharing. I hope to see you soon in other symposium.
Thank you very much. Thank you.
Oh, Doctor, there is another question. Sorry. Okay, Dr. Swee Leong, how to print for complex structure like bone scaffold using nozzle under 0.1 mm?
Yeah, correct. In fact, for most of our 3D printing technique, we are looking at the micron range, which 0.1 mm represent 100 micron, right? So we do look at micro printing for tissue engineering scaffolds in particular. So how do we make sure that the pore size are suitable? We actually design the print path based on our digital design files itself. So as well as to make sure that what is printed is as close as possible to what we design. So we need to fine tune the material as well as the printing process in terms of the process, in terms of the printing speed, for example, or even in terms of the material property like viscosity, flowability. So we do need to do what we call the process optimization for each of this material, such that what we print is what we design. Yeah.
All right. Thank you. I guess, okay. There is no more question. Thank you, Dr. Swee Leong, for such a great sharing. And we hope to see you soon in another symposium.
Sure. Thank you.
All right, next I would like to invite Dr. Teddy Shafrizal from Telkom University to share about his work. Please welcome Dr. Teddy.
All right. Is my voice clear enough?
Yeah.
Yeah. Okay. Thank you very much. All right. Okay, sorry for the trouble. All right, can I start? Okay.
But I cannot see your slide, Doctor.
Oh, sorry.
It's okay.
Entire screen. Better now?
Yeah, okay. Thank you, Doctor.
Okay. So thank you very much for the organizer. My name is Teddy Shafrizal. You can call me Teddy. I'm currently part of this Telkom University in Bandung. We are located at the western part of Java, around 3 hours by driving from our capital city, Jakarta. So today I will share some of our research in this titanium alloy development for biomedical application. So I believe in sometime in your life, you may receive some unfortunate news. This news could be in the form of accidents or some degenerative illness. All these two things may affect your bones and may need to perform some modification. And this modification could be in the form of a bone fixation or remodeling. So let's say for this case on my slide, there's a patient required to have some fixation on his bone, probably due to some fractured bone. On the other case, the thing may get even worse, whereby we need to perform total replacement. So for this case, a patient need to have a total replacement of his hip joint. And these two application or these two modification require something in common, which is a metallic implant. Even though even though this hip joint may consist of other material, but still metallic implant is considered one of the major material for this application. In the industry or the commercial metallic implant, what are the available material for this application? For my understanding, there are three types of metallic alloy that can be used for this application. Firstly is the cobalt chromium alloys and stainless steel. And the one that is very famous is titanium alloys. And this titanium alloy has become a golden standard for this metal implant, and it's very common nowadays as a commercial metal implant. And this alloy is very good in terms of the specific strength and this biocompatibility, as well as the resistance to oxidation. And I believe some of you have know this very well about this composition. The workhorse composition for this titanium alloy is a titanium with 6% aluminum and a 4% vanadium. In short, we call Ti64. There is one, what are the major challenges in titanium alloys development? So I believe this issue has been there for decades and a lot of effort in order to find out an alternative solution as a solution for these two challenges. The first one is about the toxic alloying elements that's still present in the current titanium alloy. And this alloying element may lead to hypersensitivity and to some extent may lead to degenerative illness such as Parkinson and Alzheimer's. The second challenge is the high in terms of the properties of the metal implant itself. The metal implants, due to the nature of a metal, it has a very high Young's modulus and is close to 100 gigapascal, and it's very much different from the human bone Young's modulus. This stiffness level may inhibit the bone remodeling process. I believe we have heard that in order for us to promote healthy bone, we need to apply certain load into our bone. And when we have an implant in our bones, and the implant has a high Young's modulus or high stiffness, majority of the load will be carried by this metal implant instead of the bone. Therefore, the bone will not going to have a healthy condition for remodeling process. So based on these two conditions, there's one case, probably I'll introduce these cases. There's a person who received a metal implant on one of his foot or one of his toes, and the implant was made of a Ti64. Unfortunately, after several weeks, this patient suffering from allergic reaction due to his hypersensitivity to one of the alloying element of this alloy. Therefore, this patient required to perform second surgery to remove this implant and to replace with a better one. So which means that by having a toxic element in your metal implant may introduce additional problem, and the worst will be in the form of at least in the form of second surgery. So when we look at the current commercial titanium alloy Ti64, in terms of toxicity, there's one study found that when the toxicity of this element compared with this standard commercial titanium, pure titanium, this aluminum and vanadium sits at the higher toxicity level. On the slide is on the left-hand side. Even after being alloyed with titanium, still has a still have a higher toxicity compared to the golden standard of pure titanium. Therefore, it is necessary for us have tried to find out an alternative solution to replace these two components or these two alloying elements. Right? So in order to do so, probably we need to have some understanding on how this alloying element function in the titanium alloy system. So either any of the alloying element of titanium alloy will act either as alpha stabilizers or beta stabilizer. Yeah. For this case, aluminium is typically act as alpha stabilizer, which means that this aluminium will tend to promote the formation of alpha phase, whereas vanadium tend to promote the formation of beta phase. The alternative solution or the alternative replacement for aluminium is not many as compared to the beta stabilizer. The interstitial elements such as oxygen, carbon, boron, and nitrogen are some of the candidates to replace aluminium, but they suffer from pure solubility, and to some extent, it may lead to embrittlement. There's also possibility to employ rare earth element, but they are very costly. Therefore, it's not cost efficient. And then we come into our last candidates. They are germanium and gallium. On the other hand, vanadium has more option to be replaced with neither transition metals. Most of the transition metals has a capability to support the formation of beta phase. So let's focus on germanium and gallium. So there's one study tried to compare the titanium alloy after mixing or after adding germanium and gallium. So from this data, we found that the elongation of titanium with addition of germanium has much better compared with the one with gallium, even better than pure titanium. And in terms of cell viability of this alloy, it meets the requirement of ISO and is comparable with pure titanium. Therefore, from these two data, we selected germanium as the potential replacement of the problematic aluminium in the titanium alloy compositions due to this better elongation and acceptable biocompatibility. So let me introduce you germanium. Germanium, I believe sometimes ago we heard this element probably considered as one of the earliest element to suit the requirement for semiconductor industry. However, due to the silicon technology has been moved rapidly, germanium has been replaced by silicon technology. But then recently, the silicon technology has reached close to the limit. And then the option to employ this germanium as the one of the semiconductor device is become increasing, and there's possibility that in the near future the supply and demand for these elements is increasing. Okay, in terms of this biomedical application, GE is a metalloid element similar to silicon, and it has a low risk element to human health. It is a non-carcinogenic element, non-toxic element, and in fact, it has capacity to inhibit the mutagenicity of other substances. So in some way, it helps to block the mutagenicity of other elements in the human cells. To my surprise, we have been exposed to GE for some times, due to some industrial exposure, and in fact, even in our food intake. There was a survey in a European country that found that in their dietary intake, daily dietary intake, they eat up to 3.4 milligram per day germanium in their food. So based on this background, we summarize everything, we summarize the information, and then we conducted a research based on the fact that there's a toxicity of aluminum and vanadium, and we intend to introduce and exploit the biocompatibility of germanium as a replacement, as a substitute element of aluminum. And we selected the powder metallurgy process of press sinter technique as the one that being used for this sample preparation due to this flexibility of changing the composition. And we make use of BOMB FastMet as our design tool. And then to complete the ternary system, we select Fe as a beta stabilizer element to part of this composition. And we targeted to come out with alloy with a yield strength higher than 1000 megapascal, with Young's modulus much lower than 100 gigapascal, and with elastic and measurable strain more than 1%. And hopefully we can come out with one novel new titanium alloys, which are better biocompatibility and particularly in the mechanical properties. Right, so this is our finding. We make use of BOMD map, the one that on the right hand side. Sorry. Okay, in this phase map on the top left, there's a area consists of beta titanium alloy. On the top corner right, there's an alpha titanium, and in between there's a bimodal titanium or alpha and beta titanium. In between beta titanium and alpha beta titanium, there's a region of a metal stable region, whereby this region has certain uniqueness in terms of the structure of the alloy produced. So within this metal stable region, for this case, we selected 7% Fe, titanium with 7% Fe. This region has some transformation that can be induced by plasticity. This transformation could be in the form of a phase transformation, or also in the form of changing in the way how this alloy being deformed. So based on this condition, we selected 7% of Fe in the titanium composition as our nominal starting point for our evaluation on the effect of putting germanium into the system. Right? So this is our procedure following the standard press and sinter process. We mix the elemental powder of titanium, iron, and germanium, and then we perform dry pressing, and then we perform sintering process up to 1250 degrees C. And we also conducted, in order to promote this metastability of this alloy, we perform solution treatment by heating up this alloy to 1000 degrees C for 30 minutes until it stabilizes. And then we perform rapidly quench to room temperature by ice water. Okay, so these are the findings. This is our result. So firstly, we are able to show that the omega thermal phase, which become the problematic phase in the metastable alloy, could be suppressed or disappear after germanium addition. This is one of the good news, that typically for metastable titanium alloy, this thermal phase appears in the system, and the effect of this phase is directly to impact on this Young's modulus. So instead of having low Young's modulus, by having this omega thermal, the Young's modulus is much getting higher. Therefore, once we're able to show that the GE able to suppress this omega thermal phase, seems like it's a good news for us to employ this composition with having a low Young's modulus. And then we perform hardness test. Then we found that this alloy relatively have a high Vickers hardness, more than 400 Vickers hardness, and it's very good in terms of for this processing and to maintain the surface integrity of this product. And this condition is consistently appear in as-sinter condition as well as after solution treatment. Thirdly, we also found that the expected deformation change in terms of the mechanical deformation is as following our expectation, that by having this composition, we expect to have a twinning deformation as a dominant deformation mode in this alloy. And this condition has been indicated by the presence of the straight deformation bands appear in the vicinity of this indentation. And finally, we perform mechanical testing on this alloy. And then we found that with addition of 2% of germanium, titanium 7% Fe has the lowest Young's modulus among the investigated alloy. And the Young's modulus is around 70 gigapascal, much lower than the standard of the expected target of 100 gigapascal. And this condition we suspect is due to the presence or the suppression of omega thermal phase after the addition of germanium. All right, so finally, we refer back to our initial target. So we intend to have something that has much higher than 1000 megapascal and Young's modulus lower than 100 gigapascal. And we propose this composition, titanium 7% Fe and 2% germanium, having a properties of yield strength around 1450, and then Young's modulus of stiffness around 70 gigapascal, and the elastic emission strength around 2.2%. When we compare this titanium alloy performance with other commercial alloy, sorry. It seems like I'm having problem here, so let me. Right. There's a P most like. All right, so when we propose novel alloys with the commercial titanium alloy, for this case titanium 15 zirconium and 6 aluminum 7 niobium, and also with the pure titanium implant or material, we found that these alloys sit at the preferred quadrant, having low Young's modulus and high yield strength. By this type of condition, we can suggest that this novel alloy has a potential to have a competitive advantage over the current commercial alloy. So finally, these are our contribution for this field, that we introduce germanium. Again, previously we had similar work on titanium chromium, and it's also found that it has a similar capacity or capability as a main alpha stabilizer in ternary titanium alloys. And then we also provide the evidence that germanium has a function as a omega thermal suppressor. And then the third, we're able to show that probably the 2% of germanium is a reasonable concentration for the further investigation on the effect of germanium in titanium alloys. And then finally, we propose this titanium 7% Fe and 2% Ge as a potential titanium alloy containing non-toxic element, and then it has a low Young's modulus and high elastic emission strength. With that, I'll end my presentation. Thank you very much. So for further information or further communication, you can drop me an email to this email, and I will be very happy to reply on any inquiries. Thank you very much. I return back to the moderator.
All right. Thank you, Dr. Teddy, for such an insightful sharing. So Doctor, I have a question. Okay. Comparing this germanium and titanium alloy, we know that titanium contains toxicity. So when we add the germanium, it says that it non-toxicity element. So does it like decreasing the toxicity element, or it's just like a vanishing away the toxicity of the titanium alloy itself?
All right. Yeah. So our purpose is to basically titanium is becoming a golden standard as an implant material. Okay? But then in the market, we don't have and also due to some processing issue, we intend to use titanium 6 aluminum and 4 vanadium. And these two elements, aluminum and vanadium, has a potential, even though it's a bit controversial, that it may lead to some issue later on for prolonged use. Therefore, our intention is to replace these two elements. But then for aluminium, it's a bit limited option. Therefore, for this case, we replace this aluminium with germanium, which probably has the same function, even though it has not as powerful as aluminium. But then the biocompatibility of the germanium from the previous research or previous studies saying that it is much better compared to aluminium after being alloyed with the titanium. Yeah.
All right. Thank you, Doctor. Okay, Doctor, there is a question from the floor from Mr. Irfan Alfal. He said that, how about in terms of costing, Doctor? Will it be far more expensive as compared to the current material?
All right. Yeah. So this question is quite very interesting, and is in some equation this issue always arise. I tried to compare this the price of germanium in the titanium alloy and the titanium alloy with the other alloy element, and then we found that this is there any price increment due to the replacement? I would say yes. But then how much is the increment? It will increase by around less than 5%, because the amount of germanium added into this alloy is relatively quite low. It's less than 5%, and the majority of the price is comes from the titanium itself. But then, I found that in the industry, since that in semiconductor industry, germanium is start to pick up, getting the hype of replacing the silicon. So we expect that this supply and demand for this, especially the supply of this material, will be increasing, and at the same time, the price or the commercial price will be slowly going down. And therefore, and it's very the question whether it is very have a high impact to the costing, I would say probably is very minimal and or at least acceptable region. Thank you.
All right. Thank you. Thank you, Doctor. So I don't see any more questions from the floor. So thank you, Dr. Teddy, for such an insightful sharing.
All right,
I hope
thank
to
you
see
so
you
much.
soon in any other symposium.
All right.
So that is all for today's this session. So we will be back at 2 p.m. for another session, which is our last session. And we hope to see everyone in the floor soon, 2 p.m. Thank you.
All right. Mic testing 1, 2, 3. So can you hear me, Prof. David?
Yes, good afternoon.
Excellent. So welcome back, everyone. Now we are moving to our last presentation for today's sessions. So I would like to welcome again. Assalamualaikum and afternoon, everyone. Welcome to International Symposium on Medical Devices and Technology 2023, a premier global gathering for cutting-edge advancements and game-changing discoveries. So for today's sessions, we have Professor Dr. David B. Kamajaja from University of Selangor, Senaru, Indonesia, with the topic of cell-free tissue engineering bone regeneration for implantations. So, Prof, you are ready your presentations and the floor is yours.
Good afternoon, everybody. I would like to thank for the opportunity for me to contribute to this symposium. Today, I would like to share. A topic. Hang on, please. Check. Sorry. It doesn't come out. Is the slide okay? Can you see my slide?
Yes, Prof.
Thank you. So today I would like to share topic cell-based in situ tissue engineering strategies for alveolar bone augmentation and atrophic jaws.
Sorry, Prof, to interrupt your presentation. Can you put your slide into the presentation mode or presentation view? Or slideshow view?
So how is it?
No, not yet, Prof.
Not yet.
Yeah.
Sorry, because I never used WebEx before. I usually use Zoom.
Oh, okay.
Yeah.
Okay. If in that case, maybe you can share your screen. Should be fine. Yeah. I think you just share your slide. Should be fine.
I'm trying to close all the applications first.
Mhm.
How is it now?
Yes, yes, Prof. Okay.
Okay, can I continue? I'm so sorry for this inconvenience. So let me start with the problem with the bone defect, which is frequently encountered in clinical settings. A patient with severe bone atrophy, especially in the posterior mandible or maxilla, which is a huge problem when it comes to the rehabilitations with dental implant. Dental implant needs a very good bone, either in the labial or in the lingual aspect, so that all the surface of the implant are in contact with bone. The gold standard for bone grafting is autogenous bone graft, meaning the bone taken from the patient's own tissue. It can be from intraoral source like chin bone, ramus bone, or extraoral sources like iliac crest bone. Can be done in two ways, with particulate bone and with block graft. The typical problem with autogenous bone graft is actually donor site morbidity resulting from the need for donor site, surgical site, limited availability of the donor bone, and the extended length of surgery and hospital stay. So to overcome these problems, there are other methods that can be used. For example, bone substitute with or without growth factors. Bone substitutes can be in the form of allografts, xenograft, or synthetic materials. that have been used to replace or to substitute the autogenous bone graft, but they works very well in the space-making defects, like in the cystic cavity, but for severe atrophic mandible, bone substitute alone is not sufficient because they tend to resorb very, very fast and the bone grow very slow, so resulting in inadequate quantity and quality of the regenerated bone. So that's why we need growth factors or bone forming cells to overcome this problem. This is the growth factors that is very popular until today from the year 2002. So it's been like 20 years. It's very powerful bone regenerative growth factors, but it is very expensive and not indicated in pediatric patients because of the possibility of complications, large swelling, and infections. So we're thinking of doing the tissue engineering strategy, which is actually the 3-component scaffold bioactive molecules and cells. For this purpose, we use cell-based mesenchymal stem cells. Frequent sources for MSC are bone marrow, which is actually the most widely used for bone regeneration, adipose tissue, the fat tissue from the abdomen, the umbilical cord from the fetus, and the deciduous teeth. The augmentation of atrophic mandible using cell or MSC works through these few steps. Is actually quite long and complex procedures. For example, it started with bone marrow aspiration, and then we do the isolations of MSC, and then characterizations and culture expanded MSC. So this is the culture of mesenchymal stem cells. Under the microscope, we can see many spindle-shaped cells grows on the basal, on the floor of the dish, culture dish, and this is the time when the cells are ready to be implanted. There are two options to implant the MSC to the scaffold. First is the traditional traditional tissue engineering method. As we can see in the red arrow, the culture expanded MSC is seeded on the 3D scaffolds for a couple of days or up to 7 days in the laboratory in the incubator, and then finally it is placed on the bone that we are going to augment. And the second option is do what is called in situ tissue engineering techniques, in which the culture expanded MSC is mixed with the particulate scaffold plus the growth factors, and then mixed together, and then place in the carrier, something like mesh, titanium mesh. The procedure is called guided bone regenerations. So basically, this very thin mandible can be augmented in two ways. This is the example of the cell-based in situ tissue engineering. In situ means in the place. So we bring the cells from the laboratory to the operating room, and we surgeons do the mixing of the particulate scaffold and all the ingredients ourselves. Whereas in the traditional tissue engineering, it is done by laboratory workers and then sent to the operating room in the form of the seated cell-seated scaffolds. So this is the main difference between the in situ and the traditional TE.
Sorry, Prof, for the presentation interruptions. Are we still on the second slide, Prof? Because what we've seen here is actually you're still on the second slide.
Oh.
Yeah.
Sorry.
Oh, thank you, Prof.
So this is the example of cell-based in situ tissue engineering. The bone marrow is mixed with the scaffold, which is a particulate or granule scaffold, inside the operating theater and then placed over an atrophic mandible and covered with a membrane. And then in 6 months' time, when the bone is mature, the implant can be inserted. And finally, when the implant is also integrated, we put the prosthesis, and the whole things roughly takes about 1 year. This is the example of titanium mesh carrier and GPR membrane. These two methods is actually very surgeons friendly, very convenient to do, because we are having this prefabricated mesh, and on the right hand side you can see that the implants, when has been put in the bone, there are some adhesions on some part of the implant that needs to be covered by bone. So we put the particulate and the cell and then covered with titanium reinforced membrane. So the membrane in this case we cannot use the usual membrane, the resorbable membrane, because it is not space making. We have to use the rigid one, but unfortunately this has to be taken out in about 6 months after installations because it is not resorbable. It is also the case with titanium mesh. It has to be taken out on the second stage. when we do implant. So if we compare the traditional and in situ tissue engineering for bone augmentation procedures, there are advantages of the traditional with 3D scaffold. It is very stable clinically, less technique sensitive, more stable in vertical dimension because it is a block. It's a 3D scaffolds. And reopen surgery is not required. But the major disadvantages of the 3D scaffold traditional cell-based TE is a good scaffold porosities, pore sizes, interconnecting pores, and surface roughness are very important because it is three dimensions block scaffolds that has to have a condition that enables cells and vessels to grow into the vicinity, the whole vicinity of the scaffolds. And then it requires cell seeding of the 3D scaffolds, which needs a dynamic cell seeding, not sufficient if we can use only static cell seeding. So in situ cell-based tissue engineering with GPR, advantages is we can mix the cell with the particulate scaffolds to get even distribution of the bone formation, and the bone substitute can be mixed with autologous particulate, and it enables to have an osteogenesis just like autogenous bone graft. Better bone integration, and in this case, scaffold requirements are not very critical. As long as it is osteoconductive, it is sufficient enough. But the disadvantages is it needs rigid membrane or carrier, needs to be reopened and removed because it is not resolvable, and it is kind of technique sensitive. So basically, traditional TE needs ideal scaffold and good cell seeding, whereas in situ tissue engineering, what we need is an ideal carrier or membrane. It is always important to remember that for the successful grafting, surgical skills is very important. There are few things to remember that we put graft or scaffolds or everything in the defect. There should not be any infections going on. So we have to bring down all the acute infections before we start doing the grafting. Number two is the good vascularity of the tissue bed, both on the hard and soft tissues. If we encounter, for example, a very flat bone with only cortical bone, we have to make drilling until the blood comes out, which indicating the cancellous part of the bone has breached. And this is important because the blood that we see is actually how we make the scaffolds and the cells and everything that we put there will be vascularized. The scar tissue also has to be removed because it is avascular tissue. Adequate soft tissue is also a big challenge because when we augment the bone, the soft tissue is always lacking. So it is important to do periostin release and tension-free when we close the flaps together to avoid the wound dehiscence after the surgery. And number 4, it is the stability of the graft is very important, because if we cannot achieve stability, then we do not get the bone regenerations, instead fibrous tissue formations, which is actually the sign of failure of the bone graft. So this is the area of research that we have with these protocols. In situ tissue engineering, the question is how to create a semi-rigid resorbable membrane so that we can have bone formations, but we can avoid the necessity for second surgery to remove the membrane. For traditional tissue engineering, the question is how to produce a scaffold that's bioactive to induce cell recruitment, migration, and growth. Number 3, about the cell. Is it possible to use allogenic mesenchymal stem cells instead of autologous mesenchymal stem cell? Because if so, it will be very simplified and can be cut down a lot on the cost for the laboratory procedures, which is very expensive. The mesenchymal stem cells, long procedures from the harvest until the implantations may cost about, in Indonesian rupiah, it's about 60 million, which is not very good for people who does not afford to pay for the whole things. The disadvantages of using autologous bone marrow mesenchymal stem cell, because the bone marrow quality is not always good. It's less predictable in certain cases, such as patient which is old and associated with poor systemic condition like diabetes. It's a long laboratory procedures. It takes about 3 to 4 weeks to do all these steps until the cell is ready for transplantation. There is some level of morbidity due to bone marrow procurement and the high cost of, especially because it's a kind of personalized treatment. So there is a potential clinical application of allogenic MSC in the future for bone augmentation. It is very good because it can avoid invasive procurement of patients' bone marrow, less expensive, and its potential for scaling up, so it can be commercially available. And in umbilical cord stem cell, it is very predictable quality of MSC compared to bone marrow. And the umbilical cord and dental pulp are among the most well-documented source of polygenic MSC. Yeah, this is the trial that we have ever done. It's quite a long time ago. It's 5 years back, and we tried scaffold cell strategy using the freeze-dried bovine xenograft scaffold, 3D scaffold. We seeded with the cells and put in the segmental defect of the mandible of a dog. The critical size defect is that we see here is replaced, is created in the mandible, and then put the reconstruction plate, and then the scaffold 3D. And after 9 months, when we went back in, we found that the bone forms. It is a mature bone, histologically and radiographically. It is mature bone and have a good union, but you can see here that the new bone is actually have a smaller dimension. So, as I said before, the seeding and the scaffold porosities and the physical properties are all very important for traditional TE protocol. Otherwise, all the scaffold that we place will be will absorb very fast, and although we can have a mature bone, it is always in a smaller dimension compared to the dimension of the scaffold. This is a case of the use of MSC from umbilical cord mixed with the bone graft, the scaffold. This is the in situ, so we mix the cell and the scaffold in the operating theater and place in the defect area when tooth is extracted, and then place and then replace with directly simultaneously placement of the graft and the implant with the cell inside. And the osseointegration of the implant in the bone is very good and very fast. The normal length that is required for the bone maturation is about 4 to 6 months. But in this case, only 2 months we found that the bone is already mature and implant osseointegration is achieved. This strongly associated with the bone graft with the cells that we mix during the in situ bone engineering. Thank you for your kind attention, and I'm ready for questions.
Thank you, Prof, for your presentations. So we'd like to open the floor for quick question and answer. Okay, Prof, we have one question from the floor, which is from Dr. Sroll. Usually, how long the feasible degradation rate for bone scaffold?
It depends on the type of materials of the scaffolds. The scaffold can be made from deproteinized bone, which is very hard. We call it hydroxyapatite. It is very long resorption rate. Maybe it is not completely resorbed at all. So if the scaffold is made of composite or combination between the hydroxyapatite and the resorbable bovine bone, or hydroxyapatite mixed with synthetic material, for example, 3-calcium phosphate, beta 3-calcium phosphate, the resorption rate is about 6 to 9 months. But if it is only synthetic, usually it will be resorbed away completely in about 4 months, 4 to 6 months. So it depends on the material itself. The advantage of the non-resorbable scaffold is because it will be there for about one year in case the bone growth is slow. But if the bone growth is faster, the non-resorbable or like the deproteinized, it is not favorable because it will end up in a very slow bone regeneration. So there are two kind of scaffold: bone regeneration scaffold or bone incorporation scaffold. So the non-resorbable is called the bone incorporation or the bone integration scaffold, whereas those scaffold that can dissolve or resorb completely is called the bone regeneration scaffold. So the best is actually the combinations of those kind of scaffolds. I don't know about the synthetic scaffolds because there are large kind of synthetic scaffolds that has their own degradation rate. But the ceramic-based scaffolds, synthetic ceramic-based scaffold, usually resorbs away completely, not more than 6 months.
Okay, thank you, Prof. Another last question from the floor, Dr. Hana. what kind of stem cells that should work for bone regenerations?
What type of stem cell?
Yeah.
Basically, we have various kind of sources of stem cells. The best stem cell for bone regeneration is actually those come from bone marrow, because bone marrow contain the MSC that is already genetically committed to bone formation. But bone marrow stem cells is not always predictable, because it is largely depend on the condition of the patient. It is not advisable to harvest the cells from patients who is very old, not in good conditions, have a systemic conditions, for example, patient with diabetes, uncontrolled diabetes. So the next best source of MSC is umbilical cord. Adipose tissue is not very osteogenic stem cell, although the amount of the stem cells is much larger than the MSC from the bone marrow, but genetically they are not good for osteogenesis. The next best is actually umbilical cord MSC. Umbilical cord has the advantage because it is an allogenic. It is an allogenic stem cell. The allogenic stem cells has the capacity of being transplanted without any rejection or immune response. So, as you see in my slides, we are actually planning to use the allogenic stem cells for tissue engineering, for cell therapy, and it's been widely accepted in various kind of diseases. For example, neurologic disease, cardiovascular, tissue engineering. Now, the regulation in Indonesia, the government, the Ministry of Health, coordinating regulations that allows the use of allogenic stem cells, either for cell therapy as well as tissue engineering. So it's good news actually, because allogenic stem cell can cut down a lot the cost for cell-based therapy, cell-based tissue engineering. It is very safe, can be scaled up. So we can see in the near future the commercially available mesenchymal stem cells, allogenic stem cells for various purposes.
Okay, Prof. Thank you for your insightful sharing. So now we are moving to our last presenter for today's sessions. I would like to invite Dr. Eddie Yortono from University of Western Australia. The presentation topic of health informatics, supporting the interoperability of healthcare data and its methods. So without further ado, the floor is yours, Doctor.
Thank you. I just would like to share my screen now. Okay. Right. Hopefully you can see my screen. All good?
Excellent, Prof. Yes.
Yeah. All right. Thank you so much. Hello, everyone. My special thanks for having me to the symposium committee, and greeting to my fellow speakers, colleague, and audience. My name is Eddie. I'm a health informatician by profession. I'm currently a senior scientist based on the UWA, University of Western Australia, and also a health informatician for the Harry Perkin Institute of Medical Research that located in Perth, Australia. So my topic today is about understanding the complex and diverse of the healthcare data that eventually led to an emerging new profession, which is currently much needed both for research and practical in health sector. That is the health informatics. Okay, now let's have a look on the real world data of the healthcare problem statement on my next slide. Okay, so here, I think I haven't. Yeah, okay. Here, the statement is what healthcare data uniquely challenging. Okay, we know it is very commonly understood among the healthcare profession that a significant portion of unstructured data was never meant to be structured and simply doesn't fit neatly into structured value fields. Okay, and this can be seen from the most common sources, including electronic health record. That can be like a free-form text field, or a discharge summaries from the hospital, or probably progress notes, physician clinical notes, laboratory reports, and etc., including the medical imaging and any facts record. You're probably wondering why facts record. Okay, to give emphasis, for example, the clinical notes, they are usually complex and heterogeneous and cannot be mapped to the predefined structure of the data table. Medical images such as X-ray, MRI, which are generally in the size free-will to all except highly trained professional, and also not translatable to a data table of relational database. Another interesting case example is from the fax machine. Why fax machine? In Australia, healthcare reliance on faxing also bears some responsibility to the prevalence of the unstructured data in healthcare. Despite broad adoption of the electronic health record system in the past decade, fax remain the primary means of exchanging patient information. Why? Because most of the electronic health records still do not properly support the interoperability and only offer integration with other users of their system. Okay, let's see now on the next slide here. I will discuss the role of data science in healthcare and advancement. So, why data science? Data science is fundamentally dependent on data. It, in its most basic form, a datum or a piece of information is an abstraction of a real-world entity. This can be a person, object, event, and patients. I believe we're all familiar with the terms variable, feature, attribute, in which often used interchangeably to denote the individual abstraction. Its entity is typically described by a number of attributes. As you can see in this slide, data science is fundamentally dependent on the data. And data science become useful when we have a large number of data example. So depending on the data availability. And when the patterns are too complex for humans to discover and extract manually, right? To highlight, data are generated through a process of abstraction. So any data are the result of human decision and choices. That's the highlight, human decision and choices. Therefore, we need to be careful in how we design and gather the data that we use. Then the result of our analysis will provide useful insights into our real-world problem. This can be elaborated through the data type of an attribute such as nominal, ordinal, etc. Let's move on to another slide here. As you can see on this slide, data type of an attribute affect the method we can use to analyze and understand the data. So this can be a qualitative, quantitative, or even a mixed method, including both the basic statistic we can use to describe the distribution of values that an attribute takes and the more complex algorithm we use to identify the pattern relationship between the attribute. See here, we have the type of qualitative like nominal and ordinal. Nominal can be a gender, hair color, eye color, that's for the patient, nationality, etc., even the name of the people. And then ordinal, we can see like the, for example, the melanoma numbers. Why? The time difference between the first and the second place might be not the same. Because for the melanoma cancer, we know that one patient probably can have 1, 2, or probably 11 of melanomas. So that can be an ordinal. And the other one, within the quantitative, we have discrete and continuous. Discrete, the data can be counted and they has a finite numbers of the value. This can be a total patient in hospital, a number of new patient, etc. And for the continuous, like weight, height, length, time, temperature, etc. So we all see here, we have like a structured and the unstructured data. That's the real world data problem within the health. In healthcare, structured data is predominantly used to record patient information, such as in electronic health record. Some example like medical test result or physical measure like height, weight, blood pressure, blood type, etc. And probably a drop-down menu can be used for storing demographic information. A radio button can be used to denote the patient gender, marital status, and other binary values. However, the unstructured data is too complex to be parsed and interpreted. Of course, this data can be still stored, retrieved, edited by other means. This can be medical images like positron emission tomography, PET scan, CAT, MRI, X-ray, ultrasound, etc. And also like a text file like medical notes and evaluation can be read the data if everything is, it's like unstructured. And then audio recording from speech therapy session, fax version of structured data, etc. Right. On this slide, we will see the link between data science and health informatics. All right. Health informatics link between discipline into a coordinate and coherent whole by integrating different scientific and extra scientific insight. So I just underline the extra scientific insight. This is for what? To identify science and practice around information in health that leads to inform and assist healthcare and non-health agency to anticipate the activity of the health sector. And the second one was the official definition of the WHO. Nevertheless, both definitions were tended to use a transdisciplinary approach. Why? Let's see what is transdisciplinary on the next slide. All right, transdisciplinary. It transgresses disciplinary approaches by adopting new methods and research design that are better suited to create a common understanding of complex situation. So it's a complex situation. In healthcare, everything is complex. And issues to develop practical solution. So we are tasked to develop practical solution to resolve the issue based on instrumental, scientific, ethical, and aesthetic knowledge. Therefore, transcend disciplinary boundaries and create a major reconfiguration of disciplinary division with a systematic, global, and integrated perspective. All right, here, actually, we, as a health informatician, is very rely on the data science. This is the philosophy of health informatics, the core of its discipline. It's link between health informatics and data science. From my personal perspective, this philosophy is the heart of health informatics field, as it's designed to collect, process, store, organize, and distribute information. We collect raw data, analyze them, process, organize, then structure it to become a valuable information which can be actionable as a knowledge that at the end will provide doctors to choose between possible solutions to solve a problem. However, as you can see here, the period of descriptive model now has been obsolete due to the big data challenges. Big data become useful when we have a large number of data examples and when the pattern are too complex for human to discover and extract manually. So the question when we use the descriptive model that been asked historically, such as what happened or what did happen in here, has been challenged by why is likely to happen, as you can see in here. This so-called as a predictive model with the data science as the cutting edge technology, for example, with the machine learning within the artificial intelligence, we now have been able to ask what should we do to make things happen in the above here. This is the prescriptive model for a foresight within data science. So basically, the health informatics core within the data science basically based on the data. Okay. Oh yeah, just in case you're interested to this slide, I wrote everything about this philosophy in a book chapter that will be published in Springer Nature, hopefully in October. Okay, next. This is a history of health informatics, we can see in the early work in healthcare informatics led to the founding of the we call it International Society of Cybernetic Medicine. So it was like a few decades before. And then in the period of 60 to 2000, here, health informatics went by many different names. So, however, they all mean essentially the same things, and often the term were used interchangeably. And then after that, the professionals in the field soon realized the importance of finding a universal term that would be broadly adopted to encompass the combination of science, engineering, and technology, and eventually settled on health informatics. And then in the digitized healthcare here, they have the capacity to streamline the workflow for medical clinics and hospital, and also provide added convenience for patient receiving care. However, they also have one of the biggest challenges in the industry, such as that will be come to now, such as innovation in software capability, the interoperability. Even with a single hospital system, clinic, or healthcare organization, you might find software programs from multiple vendors that are not standardized and don't communicate well or share data efficiently. That's the history of the health informatics. Now, I'll show you here the health informatics competency. This slide shows what should a health informatician have for their competencies. As a health informatician, they will retrieve, analyze, interpret, and present health data and information, which enable the planning, improvement, and delivery of patient services and care. For example, here I'll show you. We have a couple of things here. The health informatician, which is the role of the health informatic, need to be understand, apply, and analyze. So a couple of things here. For example, understanding. Health informatician interpret health sciences in health science here in order to communicate with a stakeholder and contextualize their work. So it is a must, they must understand the health sciences. And then for applying, we can see here information science and information technology. In applying competency, for instance, in IT, they need to apply information technology concept to ensure the quality information and transaction processing is correctly. And then in terms of analyzing, there are at least, as you can see here, 18 core competencies. The health informatician need to select as their area to manage healthcare data. Not everyone can do all this core competency because it's a very broad and specific in terms. This has been led to a sub-area of health informatics, which is, I can show you here. This is just among them. There are many sub-areas within the health informatics as an umbrella to encompass the rapidly evolving discipline of using computing, networking, and communication. For example, here we have the bioinformatics that focuses on the basic science question. We have clinical informatics that focuses on the delivery of healthcare. This is my role actually. And then nursing informatics that focuses on the nursing science, clinical research informatics, consumer health informatics, normally focuses on the use of mobile devices and telemedicine. And also we have the public health informatics that focuses on the research question at the population or community level. This is just part of among them. Right, I can see there are 2 questions already. That's good. And then in this slide, this is I would like to show you about the application of the health informatics. In this slide, we can see the top 10 research teams within health informatics as I cite from Mia et al. Their research title was Emerging Insight of Health Informatics Research. The objective of this research is to identify emerging direction of current health informatics research from the latest and existing studies in the health informatics domain. Okay, we have big data, telemedicine, digital health, education, smart living, edge care, ethics, even ethics, privacy and security. And also we have clinical and decision support, organizational issue, and evaluation and impact analysis. There's a lot of them. This is just only the top 10, but actually we have a lot more than this. Okay, this is also the application. In this research, this is actually my research. So in this research, my team seeks to find as much relevant research on the abundance of published work in the topic during 2013 to 2022 to identify the state-of-the-art methods and finding the gap in the research in an effort to summarize all the available evidence of distinguished real-time automatic arrhythmia detection. In here, we use quantitative research process of systematic literature review, SLR, it's a very common, within the health informatics area to identify, analyze the trends, the data sets, and methods in real-time arrhythmia detection. So the specialty in this research is actually to identify and analyze the trend. And the systematics, searches were administered in a Scopus using a defined search string and with several filters we were applied based on inclusion and exclusion criteria, as you can see here, from 20K studies that can be done manually. 20K studies on detection of arrhythmias. Okay. So after the 20K thing, we remove duplicates and non-eligible article using the algorithm. Yeah, because manually normally can be done. The data were extracted from the selected articles with the results so that the number of study focusing on the real-time arrhythmia is still limited, but on a rising trend. Only 1K or 6% of the study was focused on the arrhythmia. And here, finally, the analysis of the data set, feature extraction, classification method, and table algorithm comparison were presented as the result of the study, which summarize the preeminent methods of real-time arrhythmia classification based on its average accuracy here. This research has been done via complex search string from the structured and unstructured data. So it's very complex. Another example for the application can be seen in here. Actually, you can browse WA Kirkbride Melanoma Advisory Service. They have the website. This is an example of the clinical informatics. I work here, and this is my day-to-day role. This melanoma advisory service provide information and advice to patient and doctors. So it's not provide information only to patient, but also the doctors about the melanoma cancer. We have a panel of specialists made up of from the pathologists, dermatologists, plastic surgeon, medical, and radiation oncologists who meet together to determine how to treat a particular melanoma condition because it's a very, very complex things. So what is my job here as a health informatician is to make sure that all the patient data ranging from the demographic view, the clinical data, biopsy and pathological data, including staging records correctly and manage them, analyze and modeling them within the health information discipline. So this is very timeful, but if we do this using, it's like a machine learning within the AI, it can be done just a few minutes. Okay, next. Here, this is a sample from a pathologist's internal case audit report. Very simple, but yet it has a powerful audit outcome to manage the error within the pathology report. It looks very simple, but actually it will manage the error within the pathology report. Of course, we don't want any human error when it comes to health diagnosis. So this one has been designed and presented just, if a pathologist fill this form, blah, 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 and then they submit this form, it will be automatically seen the audit outcome did. Next one. These are example of a prescriptive and predictive model that lies in the health informatics philosophy, the data science. For example, in here we have the cancer prognosis. This is for the breast cancer prognosis. Yeah, you can browse in here. You can see, and then we have the melanoma outcome calculator in here. And then, oh, this one is also interesting because this is a risk calculator for melanoma based on Australia geography ultraviolet level. So we can predict the most dangerous geography that will affect melanoma cancer in Australia and so on. Okay. I think this one will be my final one. I just wanted to get everyone on board. What are the challenges of addressing digital health were significantly different among and within countries? Even is in Australia or in Indonesia or in Malaysia or probably in Thailand. For example, like we have a different policy and law and security. Does the regulation protect the privacy of data? And then we have like a global management strategy. Global is like global and a local management. So how to implement a good example of digital world strategy to your country? This is obviously not apple to apple. Governance. how to manage information flow and access to information between different level. For example, like local or national initiative or between states. Yeah, we need to govern this. And then, is there any continuity development? Do we have a clear holistic roadmap? Yeah. What about collaboration? How could intergovernmental collaboration contribute to digital healthcare effort to face healthcare challenges? And then digital literacy, how we measure digital skill, that like technological skill and communicate information on various of digital platform. Also, of course, digital infrastructure. And do we have this? The health information role. Do you think health informatics can play a significant role in implementing digital health in your organization or your country? Okay, that will be my final slide. This is the reference. I have included all the link as well. I'm happy to share my presentation to you all. I'm happy to be contacted via LinkedIn if you're interested and to have more discussion in the future. And thank you very much.
Okay, thank you very much, Prof. Dr. Edi, for your presentations. We have a couple of questions from the floor. And the first question comes from Mr. Ruba. Basically, in your opinion, is it how much important for especially researcher, skilled worker from non-medical backgrounds, well collaboratively or engaged in medical sectors to have insight on medical technologies and our basic health issues? So how it may have more if someone from non-medical background have better knowledge about some of the basic medical procedures. So that would be the first question, Doctor.
Okay, yeah, I saw a couple of places already. That's great, actually. Yeah, a good question. It was a good question. You know, if I mentioned about the transdisciplinary before, so actually that's give some example that from not non-medical background also can be a health informatician, but we need like additional knowledge. Of course, if we working on the health settings, we need very good knowledge within the health systems. So, for example, like I saw you before on my slide about the health information competency, as you can see, there are a couple of areas that we need to know. Otherwise, it will be very hard to comprehend all the medical terms. It's it took me at least like 5 years just only to to become a health informatician in melanoma cancer. So it's a very challenging, but it can be done. So yes, it can come from non-medical background.
Thank you. And the next question would be, what are some common challenges in making healthcare data more interpretable for healthcare professional and decision maker?
That very good. We know that all the practitioners are busy. Every one of them very busy, and I gave them 2 thumbs between their personal life and also their professional life, 2 thumbs for them. So we would like to make things easier for their life. That's the health informatics. So we can provide things that, for example, like, it's like The challenge is more about the data availability. For example, if we would like to have an algorithm that can predict the breast cancer from, for example, in here, like from the ultrasound. So we need a various data from medical imaging in ultrasound. That's from diverse geography and multiple hospital data. The challenge will be how we get the data. That's the number one challenge. So in here, basically in Australia, we don't have that challenges, but I have that challenges if I go to another country and then a deep dive going to research with them. That's will be a challenging. But in here, we have a one rooftop like bridging to access all the data. So basically depend on what the policy and regulation in your country actually. Yeah.
All right. Another question from Muhammad Atikur Rahman. So are there specific machine learning algorithms or models that are better suited for generating interpretable results in healthcare and data analysis?
Oh, yeah. This is a very broad question. Actually, we don't have the specific one. It will be depend on the case. So, for example, in the melanoma cancer, we have a couple of things based on the MDT. MDT is multidisciplinary team that will be examine the patient within the cancer. We have the pathologies, anatomical pathologies. We have the surgeon. We have the oncologists and etc. So within the multidisciplinary team, we try to extract all the information that would be very insightful for the practice for the physicians, the specialists. So in one, I can say in one window, they can see all the information by very simple, and then they can um, they can predefine what would be the relational within the disease, within the what types of the disease. For example, like one patient have the melanoma, but also he or she have the colon cancer. That will be a very complex thing. So yes, the machine learning, anything with machine learning within the AI can do all the algorithm to extract all the valuable information for the doctors. Very specific.
Okay. All right. And last but not least, how do you see the role of artificial intelligence evolving healthcare data interpretability in the coming years?
Okay. I can see it's a very brightful. Why? For example, I'm doing now like research within the breast cancers. In my team, they try to learn about of the predictive using the ultrasound. This is just only ultrasound, not the mammogram. Within the ultrasound, that can be make all the radiation doctors more simple to see all the outcome of the information. So in here, it's still in trial, but it make life easier for them. It's like AI is the future, but currently we already involved within the AI. So very brightful.
Okay, thank you very much, Dr. Eddie, for brilliant sharing. And basically, that will sum up today presentations for second day symposiums and international symposiums. With that, I would like to thank you again to our presenter, Prof. David and Dr. Eddie, for brilliant sharing. So with that, I would like to pass the sessions to Muhammad Atikur Rahman for the closing ceremony. Thank you.
Thank you very much.
Ladies and gentlemen, distinguished guests and fellow innovators, I, Muhammad Atikur Rahman, is a scholar in UTM, is truly honored to address you at the closing ceremony of International Symposium on Medical Devices and Technology 2023. Over the past 2 days, we have witnessed an incredible convergence of minds, ideas, and innovations in the field of medical devices and technology. This symposium has been nothing short of remarkable. We embark on this journey with a shared vision, a vision of future where healthcare is not just about treating ailments, but enhancing lives, where technology is not just a tool, but a partner in our well-being. Throughout this symposium, we have immersed ourselves in a world of innovation and collaboration, exploring the latest trends, breakthroughs, and best practices that will shape the future of healthcare. Our keynote speakers, renowned experts in their fields, have shared their invaluable insights and predictions, illuminating the path forward for medical technology. Their wisdom has guided us, inspired us to push the boundaries of what is possible. The research presentations we have witnessed have unveiled groundbreaking studies and innovations, each one a step closer to the revolutionizing the way we approach healthcare. The dedication and brilliance of these researchers who presented their work here will undoubtedly have a lasting impact on the world. Moreover, the network opportunities provided at this symposium have allowed us to connect with industry, leaders, researchers, and investors. These connections will serve as a foundation for future collaborations, partnerships, and breakthroughs that will transform the healthcare landscape. Let us not forget the importance of continuing education. Through the shade of knowledge by our presenters, we have all had the opportunity to enhance our professional growth. This is a symposium that doesn't just end here. It is a springboard for further learning and development. As we close this remarkable event, I encourage each one of you to take the knowledge, insights, and connection gained here and carry them forward into your work. Let be the catalyst for the change, the champions of innovation, and driving force behind a brighter future in healthcare. So I would like to invite Associate Professor Engineer Dr. Ardina Siahram to give his closing speech.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And good afternoon to everyone. Engineer Teknologi Data Nur Hasrul Akmal bin Ngadiman, Program Chair, International Symposium on Medical Device and Technology 2023. Honorary speakers, distinguished guests, ladies and gentlemen. On behalf of Medical Device and Technology Center, Institute Human-Centered Engineering, University Technology Malaysia, it's a great pleasure to thank to all of you to the becomes International Symposium on Medical Device and Technology 2023. Today, we have gathered together to connecting dots, actually to develop networking. This symposium we developed actually to improve, to it's become ecosystem, become our bridging to connect to everybody, especially in medical device technology niche area. In MEDiTEC, yeah, we have 3 niche area, which is the first is implant technology, second is bioinformatics, third is biosensor. We work together, yeah, to develop something better for healthcare, and we also invite to everybody, our counterparts in university, industry, and authority, or to become from the government to become our partners. During these 2 days symposium, I believe all the presenters, all our keynote speaker actually gave a lot of impact, a lot of knowledge, yeah, and become the good sharing to anybody. With this end, I hope with this event we can develop association. For example, like association for medical device technology, that is if we can develop it, or we can develop the association that is benefit to ours, to all, to connect, so they will improve our quality research, because it's become multidisciplines. And for next year, yeah, this symposium will we will continuously, yeah, it become yearly event in the Medical Device Technology Center. I think that one is become next. Maybe we can invite as general meetings. Yeah, we can sit down together. We can discuss together. Yeah, and at the end we can develop another new niche area, or we can generate a new program for improve the quality or the better life for human being. This symposium from our symposium is from the 7 countries, 15 universities, 1 from authorities, and 1 from the research institutes. I believe with this foundation for next symposium, we can invite is more countries, more university, and more government agencies or authorities, and we can invite also more research institutes. With that one, I believe we can develop the good ecosystem in the world, especially in medical device. With that one, I thank you, really thanks to organized committee. Yeah, I express my heartfelt gratitude for their dedication and hard work in planning, execution this symposium. I believe the commitment to excellence has ensured that we have a program enriched in the content, diverse perspective, and designed for facilitate meaningful engagement. I really thanks to the Tasrul as program chair for this symposium. Lastly, thank you so much from all the keynotes on this symposium, International Symposium on Medical Device and Technology 2023. I believe for next year, we can develop a better symposium. Thank you so much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Prof, for your valuable speech. Before closing, I would like to extend my heartfelt gratitude to the organizing committee, the presenters, the participants, and all those who have contributed to the success of the symposium. Your dedication and passion are what made this event a resounding success. In closing, I will leave you with the reminder that innovation is not an end, but a journey. Let us continue to push the boundaries of what is possible, to challenge the status quo, and to work tirelessly towards better healthcare for all. Together we can and will shape a brighter future. Thank you, and may the spirit of innovation continue to guide our endeavors. Innovation for better healthcare is not just a slogan, it's our mission. Farewell, and until we will meet again on this remarkable journey of discovery and progress. So there is a international conference, International Medical Devices and Technology Conference, third Medical International Conference in UTM on 30 and 31st October 2023 at Concord Hotel, Kuala Lumpur. So this is a promotion for the call for the papers. So kindly look at the website link, which is given in the available chart, research.utm.my. So now there will be a photo session. So kindly all the participants and all the presenters can open your camera for the picture.
Right. 3, 2, 1, smile. One more, 3, 2, 1, smile. Relax, look. 3, 2, 1. Okay, see you.
Thank you, and the certificate will be made to your email. Thank you very much.
Thank you, Dr. Eddie. Nice to meet you, Prof. David, Prof. Hassan.
Thank you, everyone.
Thank you. Thank you.
Thank you.
Good job.
Mm-hmm.